Okay. Thank you very much, Agrawal sir. And good evening to everyone. My name is Abhishek, and I represent Dr. Reddy's. In fact, no, I am very much thankful to sir for helping us and guiding us through this entire program. Only the thought we were discussing and this thought came, and I think sir was, as Dr. Nair was telling, he was like, no, he has been creating new benchmarks. So, and this entire 5-day program had been churned out in no time. Just before I hand over to sir, I just thought of sharing three things that Dr. Reddy's is working on, which is quite futuristic. One, of course, I had shared a few times on various platforms. One is, of course, and Dr. Reddy's has been quite advanced stage in terms of bringing CAR-T for Indian patients. The first one to come will be the BCMA, and the following one will be the CD19. The second thing also is quite interesting in this era of immunotherapy. We have our research molecule that is again the first oral immunotherapy that we are working on. It's works on PD-1 as well as VISTA. So that will go in clinical trial soon. And we are also working in the space of VGFR. That also is an instrument, it's very in a very initial stages of phase 1. So three things I thought it will just share and hand it over to Agrawal sir for the next part of the program. Thank you very much.
Thank you, Mr. Abhishek. Dr. Reddy's is progressing by leaps and bounds. These three announcements are fantastic. So coming to the webinar. So this idea of 5 days webinar was conceived by Dr. Reddy's and executed by Mumbai Hematology Group. And it was named Year in Review, Hematology 201, with the idea that we are going to discuss what has happened either in the form of presentation or publication during last 9 to 10 months in the calendar year of 2021. So that forms the contents of today's webinar. And I must thank Dr. Reddy's for conceiving this idea and helping us in implementing it. One of the major announcements which I thought Abhishek will make, but he didn't make, so I'll make it on his behalf, is the launch of oral azacitidine. Something fantastic. Large number of AML patients cannot undergo bone marrow transplantation. Some of them cannot even receive intensification. They've achieved CR or CRI, and that's the group of patients, especially who are elderly, that they can be for the first time very successfully given an oral agent in the form of oral azacitidine, 2 weeks on, 2 weeks off, and the progression-free survival, and not only that, the overall survival has been doubled. So congratulations to Dr. Reddy's for launching this very soon. Oral azacitidine is very relevant to the subject that we are discussing today, and you're going to hear a large amount of this by Dr. Bhausai Bagal at about 8:40 p.m. today. All our in last 1 year, 8 months have been managed by Mice Ideas. And I'm grateful to them for a flawless exhibition of all that what we are doing. A lot of hard work goes in. It is not seen, but behind the curtain is a large amount of pain and sweat that takes place in organizing these webinars, and I thank Mice Ideas for that. Today is day 3, Wednesday, 20th of October. Subject today is acute leukemia, predominantly acute myeloblastic leukemia. Our chief guest today, and he needs no introduction, and we are honored to have Lieutenant General Dr. Velu Nair, MD Medicine, FRCP London, FRCP Glasgow, FACP US, FICP, FAMS, FIACM, FUI, CC UK, and Fellow of in the Indian Society of Hematology and Transfusion Medicine. Group Head and Chief Consultant, Comprehensive Blood and Cancer Centers, Ahmedabad. Gold medalist in MBBS 1977 from AFMC, first position from Pune University. MD Medicine 1987 from AFMC, once again, first position in AFMC Pune. Postdoctoral fellowship in hematology and bone marrow transplant from 3 very prestigious institutions: CMC Vellore, King's College and Hospital London, and Stanford Medical Center and University US. Formerly, he was Director General of Medical Services, Army, and Call Commandant, President's Honorary Surgeon, Dean and Deputy Commandant, AFMC Pune, Dean, Army College of Medical Sciences, New Delhi, Professor and HOD, Department of Clinical Hematology in BMT, Army Hospital, New Delhi, and AFMC Pune. President of the National Society of Hematology and Transfusion Medicine, 2006 and 7. President of Delhi Society of Hematology, 2009 and 10. Member of National Apex Committee for Stem Cell Research and Therapy, ICMR. Member of the Drafting Committee of ICMR Group for developing guidelines for stem cell therapy and research in India. Member of the ICMR Group on Antimicrobial Stewardship Program. Co-chairman of Task Force for Stem Cells and Regenerative Medicine of DBT. National Project Coordinator for 2 large multi-centric R&D projects of DBT on stem cells for cardiac and neuroregeneration, 2007 to 2010. Presently, Chairman of the Nuclear Accident Management Committee of APBMT, Convener for Drafting Curriculum Syllabi for DRNB courses in Clinical Hematology, NBE, elected Council Member of National Academy of Medical Sciences, Chair, Co-Chair, member of various committees of ICMR, DBT, DRDO, NABH, including Chairman of Scientific Advisory Committee of NIV, ICMR Pune, NIH, ICMR Mumbai, Chairman Program Monitoring cum Steering Committee of DBT for Stem Cell Hematology Research, Indo-Japan, Chairman of the Drafting Committee of ICMR for the National Guidelines, BMT 2021, Chairman of Accreditation Committee, NABH, Co-Chairman for the Working Committee to develop ICMR National Marrow Donor Registry, Co-Chairman for CAR-T Cell Research Committee of DBT, Member of the Performance Evaluation Committee of ICMR, Editor-in-Chief of QAI Journal for Healthcare Quality and Patient Safety, and Member of Editorial Board of Indian Journal of Medical Research. Development of hematology and BMT services, his contribution can never be denied. He developed the establishment of 7 hematology and BMT centers in armed forces. Teacher and examiner for MD and DNB medicine and DM hematology. Keen researcher who's conducted some of the landmark clinical trials in stem cells, hospital infection, thrombosis, and hematological malignancies. Extensively published over 250 articles, chapters in international, national peer-reviewed journals and books, authored 3 textbooks in medicine. Section editor for the API textbook of medicine for the 11th and 12th edition. Huge number of awards, just to enumerate a few: prestigious Presidential Award for Distinguished Services in the Armed Forces, Param Vishisht Seva Medal, Ati Vishisht Seva Medal, Vishisht Seva Medal twice. Awarded the Scroll for Excellence in Medical Education by NBE. Recipient of 19 prestigious civil awards from various national societies. Ladies and gentlemen, join me in welcoming Lieutenant General Dr. Velu Nair to inaugurate our today's webinar and give us some words of wisdom.
Thank you, sir. Thank you very much indeed for those kind words and having invited me to actually be a guest of honor in this prestigious meeting of yours. At the outset, I want to heartily congratulate you for putting together this 5-day academic feast on a thematic basis, along with Dr. Reddy's, who've done a good job in projecting this whole meeting. Dr. Agarwal never stops to amaze me. He's not only tireless, he's like a marathoner. He continues to organize a series of academic events and has taught us how to navigate during this COVID pandemic, and I want to thank him profoundly for that. Another thing which I've always said about him is he's inclusive. He's inclusive people from all age groups, seniorities, so that's a great thing. Number 2, he keeps changing the format, so people are excited and they keep getting involved and the interest is sustained, which again are very, very excellent qualities. Today we discuss AML, which is a heterogeneous disease and extremely challenging to treat. It's not only labor and time intensive, but as we all know, it's very capital intensive too. Advances have been made in the understanding of the pathobiology of acute myeloid leukemia, leading to the latest ELN classification of 2017 and the WHO. With molecular targets of driver mutations being identified, the treatment paradigm for AML is rapidly evolving. There's a record number of molecules which the FDA has cleared, total of 11 agents since 2000. And out of these 11, 9 are since 2017, which just show there's a flurry of agents which are coming, and there are many of them are already hit the market, and even some of them have generics. Along with this, I like to say that there are advances in the low intensity treatment also. This is for patients who are unfit to undergo standard inductions, and they are able to achieve reasonable disease control. You just heard about oral azacitidine. There are other such agents which I'm sure is being discussed today. So with this, we have all the targets, right from the new FLT3 inhibitors, right from midostaurin to the HMAs, EZA and decitabine. Then you have the IDH1 and 2 inhibitors. Then you have the BCL2 inhibitor, which is venetoclax. So there's a plethora of these molecules. Now, what's important is to put them all in the right slot. And the second thing is, can we combine them? Do they have synergy? And of course, the role for maintenance treatment, I'm sure it will come up in today's treatment. Of course, BMT, bone marrow transplant, remains an eminently curative option, but it's got its own limitation in terms of cost and its morbidity and mortality, which has been reduced to an extremely small percentage. So BMT, of course, is one of the oldest curative treatments which has come of age, and over 1 million transplants have been done, and this has been published in 2013-14. Now, I would just like to tell you the determinants of the outcome here, being a heterogeneous disease, from the highly curable 75% to the highly adverse, where it can be less than 10%. And this will be discussed today, but this is the range, you see, and they are hugely patient related. And he just told you, Dr. Agarwal told you that from 10 to 15% 5-year survivals, we are talking of 75% and above. This is not about APML. There are other good risk AMLs. So we have come a long way in being able to harness the disease here. The last two things I want to say is, one is the center expertise, the center experience. That's so very important. And better the center experience, lesser the mortality at 4 weeks. It's been shown in developed countries too. So ladies and gentlemen, AML requires cumulative expertise, constant monitoring, prompt and readily available supportive care, always with antimicrobials and blood components. We've come a long way and we have important generics hitting the market, and we hope to improve the outcomes in this difficult to treat disease. With these words, I'd like to inaugurate this meet and wish the meet all the very best. Thank you very much, Dr. Agarwal and Dr. Reddy's lab. Thank you. Jai Hind.
Thank you, Lieutenant General Dr. Velu Nair, for those golden words. In these 5 minutes, you have narrated probably the whole summary of what's going to take place in that next 3 hours. Each sentence, each word conveyed so much. I am grateful to you. Moving on, for those who have logged in a bit late, the idea of this 5 days marathon was conceived by Dr. Reddy's, and Mumbai Hematology Group executed it. It was named Year in Review, Hematology 2021, with the idea that we are going to discuss chiefly what was presented or published in these 10 months of 2021. Dr. Reddy's is launching oral azacitidine, about which Lieutenant Colonel Dr. Velu Nair just mentioned. We have 4 parts of this webinar, and the first part is the lecture. And my friend and colleague, Dr. Pravas Mishra, Director of Hematology and BMT from Max Hospitals from New Delhi, is going to begin our webinar with a wonderful title, How do I investigate a newly diagnosed AML? Not only that, tests that make sense in India. So this is a very exciting title that he has chosen. And let's now listen to Dr. Pravas Mishra.
Thank you, Professor Agarwal. That is indeed an honor to be counted among your friends. I would rather think of myself as a student. And thank you, Dr. Velu Nair, for a wonderful introduction to the whole topic. As Dr. Agarwal has said, you have pretty much covered everything. I'll just stop my video here because that's a bit distracting when I'm speaking. So my topic is, how do I investigate a newly diagnosed acute myeloid leukemia? Tests that make sense in India. I'm Dr. Pravas Mishra and I work in Max Hospitals in New Delhi. So when I investigate a patient with a suspected acute myeloid leukemia, the main purpose, of course, firstly, establish the diagnosis, thereafter identify the AML subtype, possibly risk stratify the patient, predict prognosis, and thereafter potentially formulate treatment strategies. And in my practice, it is primarily the decision to advise allogenic stem cell transplant in a given case. So this is how we start out with a suspected case of acute myeloid leukemia. We look at a peripheral smear and we start looking at these blasts. Subsequently, we do a bone marrow aspirate, a bone marrow biopsy. So this is a patient where we had done a bone marrow aspirate, and this had shown the so these had then shown the typical blasts. For those of us who used to look at cytochemistry slides, I do not know whether this is now commonly used in most centers, but we used to see cytochemistry slides when I was at AIIMS. And this is a myeloperoxidase stain. This is combined esterase in AML M5. And here we have a chloroacetate positive dysplastic eosinophils and neutrophils in a case who subsequently had inversion 16. But in almost all practices, cytochemistry has now been overtaken by immunophenotyping. So after looking at the morphology of the bone marrow aspirate and the biopsy, we straight away go to immunophenotyping, and we generally get something like this, where all the markers are there, and we see whether this is an acute myeloid leukemia and possibly which FAB subtype. You might also get the graphs to go with it, but most cases you would simply get this kind of a report. So the immunophenotype might give you potential clues regarding underlying mutations, cytogenetic abnormalities, and prognosis. For example, aberrant CD2 expression is associated with a FLT3, CD34 positive blasts with mutated NPM, and then acute myeloid leukemia with myelodysplasia related changes, which might also present with some typical immunophenotypic features. But these are merely associations, and we cannot really base our decisions on these associations alone. We also do a bone marrow biopsy. The bone marrow biopsy is particularly useful if your bone marrow aspirate has been dilute or you have not been able to get sufficient material due to any reason. You would be able to do immunohistochemistry on the biopsy with starting with CD34 and various other markers. If you have immunohistochemistry, the capacity to do it in your lab, it would be useful for those cases where you have got an extramedullary disease as well. I do a CSF evaluation at baseline for almost all my children who present with acute myeloid leukemia, but for adults 18 years and above, I would do a CSF evaluation only if the patient has got neurological symptoms or signs at the baseline. I follow the NCCN guidelines to decide on treatment strategies in both patients who are less than 60 years of age and those who are older than 60 years of age. Therefore, following the NCCN guidelines, I would try to risk stratify my patients into categories. So I would like to see whether they're in the favorable risk group, where they might have the T821, inversion 16, mutated NPM without FLT3, or the intermediate group, or you could have the poor or adverse risk groups. All of these keep on increasing day by day. So these are the risk categories that I would look for. Whether you are following the ELN, the ASCO, or any other such guideline with few minor modifications, they're essentially the same. So to achieve this, I would again follow the guidelines which say that you need to obtain adequate samples. So I obtain adequate samples of bone marrow and peripheral blood at diagnosis, of course, for the morphology and immunophenotyping, followed by cytogenetic testing by karyotyping. So I do the karyotyping. The NCCN advocates FISH cytogenetic analysis. However, I do multiplex PCR because this also, as with the FISH, this also allows for a rapid screening to identify either favorable or unfavorable risk groups. I also do additional molecular tests such as NGS because this helps me provide a full picture of the genetic factors that would contribute to a risk in a given patient. So cytogenetic analysis, the karyotyping is still the gold standard. However, it might not detect certain cryptic deletions and subtle translocations. Therefore, the FISH studies or multiplex PCR is also to be done. Now, this is a patient in whom we had done, so the cytogenetics were done. They come later on. We get these results earlier. So this was sent, as you can see from the top here, this was sent on the 9th. By the 12th, we had these results. So we usually get this within 48 hours. So you would, particularly in case you have missed out on any, in the morphology, if you had missed out APML, so this is a time point where you can change your strategy. Cytogenetics comes later. So we generally get our cytogenetic reports within 7 to 10 days. This is the same patient on the right-hand side, is the same patient as the previous one, where the translocation 821. This is another patient who had normal cytogenetics. Now, the whole crux of using further molecular testing is for these group of patients who have got normal cytogenetics and normal multiplex PCR. So this is a heterogeneous group in AML who have got a normal karyotype AML. These are seen in about 40 to 50% of the cases. And we do not know, if we do not do further tests, we do not know whether these are these require transplant or any additional treatment. So particularly in this group of patients, the next generation sequencing is useful. Now, this was a patient of mine who had normal cytogenetics to begin with. And this results generally come within 3 weeks, 2 to 3 weeks. And in this patient, we had found relevant mutations in TET2 and NRAS. So this immediately tells me that this is someone with an adverse prognosis. And if this person goes into remission, then we should be advocating the stem cell transplant as a consolidation strategy. So the NCCN 2021, so they include several specific prognosis are given in a subset of patients, and these might also guide treatment decisions. So presently, the CKET, FLT3, NPM1, IDH1, IDH2, RUNX1, ASXL1, TP53, BCR-ABL, and PMR-RR alpha. So these are included in these group. These are the ones that you need to see. But if you're going to use a commercially available test, you would be looking at nearly 100 mutations. So these are the common mutations that are we currently have information on. We have obviously information on FLT3, then we've got some information on DMT3A, RUNX1, AXXL1, KIT, NRAS, TET2, and TP53, which are associated with adverse prognosis. Then again, we have got NPM1 and SEPA, which are associated with a good prognosis. IDH2 and IDH1 are important because they have certain targets. So you can use for molecules which are targeted against these, either those or the venetoclax, which is easily available to us, can be used in this group of patients. Particularly RUNX1 has got an adverse prognosis. This is mostly in the context of a normal karyotype patient. Since 2017, several molecules have been approved. We have midostaurin, which is useful in FLT3 mutated both ITD and TKD mutations. Then we have got ivosidenib, enasidenib for IDH1 and IDH2. We have now oral decitabine or oral hypomethylating agent, which has been approved in adults with MDS or CMML. We have got oral azacitidine, which Dr. Agarwal just mentioned. This has been used in those patients, those adult patients who have achieved first complete remission, after an intensive chemotherapy, and somehow, for some reason, are not able to take definitive therapy beyond that. So you could use oral azacitidine in those cases. And then another interesting information that we have regarding gemtuzumab ozogamicin in those patients, particularly who have got a c-KIT mutation. There are some studies which suggest that this addition of gemtuzumab ozogamicin or Mylotarg might overcome the adverse feature of c-KIT and avoid transplant in those cases. Coming to MRD monitoring, I use immunophenotyping. So multicolor flow cytometry is used. I use a cutoff of 0.1% to tell whether the person is MRD positive or MRD negative. Molecular markers, particularly in the favorable risk group, APL, CBF, AML, and NPM1 positive AML. So this is how we use it. So PML, RR alpha, RUNX1, so 821, CBF, MYH11 or mutated NPM1. So I do a molecular MRD assessment every 3 months for 24 months. So if you are using NPM1, you can use a peripheral blood. For the rest, you can use a bone marrow. I currently do not, following the ELN criteria, ELN recommendations, I currently do not use any of the other mutations that I might detect during NGS testing as a MRD. So Grimward and Yin are two investigators who have done a lot of work in MRD testing. So during follow-up, if you are using 821, then if I find more than 500 copies on two consecutive occasions, then it is time for us to intervene. Similarly, for inversion 16, if there are more than 50 copies at any given time point, then you are looking at a chance of 100% relapse over the next few months. And therefore, you must then intervene. So my approach to tests and investigations is, does an intervention save life? Does an investigation lead to an intervention that could save life or it could prolong a life? Whether this additional prognostic information that I'm getting, am I getting it at a reasonable cost? And finally, I do have the medico-legal aspects in mind also, because we are bound to conform to an expected level of care. We are a heterogeneous country, and in various parts of a country, we may not have all the facilities, but we are bound to conform to an expected level of care in which we are practicing. So in my center, a person would spend approximately 50,000. This is for the core acute myeloid leukemia workup, including the molecular PCR, and the NGS might spend approximately 50,000 rupees, out of which the NGS is approximately 16,500. I think this is reasonable, particularly if the patient will be willing to consider an allogenic stem cell transplant at consolidation. This paper, the SEER database, has recently come out, and this looked at patients of acute myeloid leukemia treated between 1980 to 2017 in America, in the United States of America. Now, this graph, you do not look at it in great detail, but what this graph and this other one, these figures, they show is that over a period of time, in all risk groups and any age, there have been a tremendous improvement in overall outcome of patients with acute myeloid leukemia. And this improvement in survival has not come because of utilization of any novel therapeutics or novel investigative modalities. These have come out because of introduction of high-dose cytarabine consolidation into the treatment of younger patients, safer allogenic transplant protocols. You could use RIG transplants in older age group and those patients who are not very fit, better supportive care measures, better blood bank facilities, faster access to an emergency center, improved antibiotic and antifungal therapies, antibiotic prophylaxis, antifungal prophylaxis, all of which are very easily doable and something that we should strive for. Do we have any Indian guidelines which would guide us, because every time we give this kind of a talk, people say, do we have any guidelines in our country? And we do have guidelines from ICMR. These were published in 2019, and several big names in the country are part of this. I'll be completing it in about a minute. So these guidelines do not give any option to not do a molecular studies, because they do differentiate between intermediate and unfavorable risk. And where they're looking at transplant, you need to do all the tests available to you. So the expected level of care is to provide improved, so you should have good supportive care, you should adhere to the curative options in all eligible patients. This would be the reasonable standard of care that you are providing. And to do this, you would need to do almost all the tests that are available to you, keeping in mind that these could be limited by the expertise, standardization, and perhaps actual applications. Okay.
What that was, I don't know, but it just... Anyway, we have some questions from the audience, and I'm sure that the faculty here also will have some questions. And those of you who are around, please open your video, join us. We'll have an interactive discussion. Pravas has left us with a lot of time. There's one question flying here from Dr. Mona Vijayaran. Why is TAT2 NRAS adverse risk?
Yeah, so why is TAT2 NRAS? So these are basically associations. So people have found that these are associated with patients who are, who do not have a very good outcome. So you got TAT2, NRAS, ASXL1. So these are all associated with a poor outcome. Just the way that initially when you did cytogenetics and you did FISH, you would get certain, you now have over a period of time. When you found 821 to begin with, you did not know that this is associated with a favorable outcome. So this is all over a period of time. So currently, during my slides, I wanted to add that currently we do not know for sure that how well these newer modalities of investigations and treatment are actually going to affect the outcome. The second question is from Dr. Vishwa Prakash. So we get a dry tap due to a packed marrow. In such cases, do you send peripheral blood sample for cytogenetics, or how can we proceed in such circumstances? Yes, so if you have got a dry packed marrow, we do send a peripheral blood for molecular testing, and we would also send it for NGS. If we do have a significant number of blasts in the peripheral blood, then we might also send it for cytogenetics, with the understanding that the routine karyotyping might not pick up the relevant information. There is a question again from Dr. Biswa Prakash. What's your antibiotic and antifungal of choice as prophylaxis? So I use levofloxacin and fluconazole as prophylaxis in my AML induction. I do not use posaconazole. Dr. Savitri Singh,
before you proceed, Pravas, can I ask you, why are you not using posaconazole?
Costly, sir.
Sorry for cost.
Yes, sir.
That's the only reason, right?
Yes, absolutely.
Fair enough. Okay. Yes.
And I have been using fluconazole for now nearly 15 years, and I find it quite useful. I don't see any reason to change, unless Dr. Savitri Singh, do you do MRD each time bone marrow aspirate to the lab for remission status, or if we see more than 5% blast? No, if I see more than 5% blast on the aspirate, I do not send it for MRD. I mean, if my pathologist could tell me that, then it's not required.
Quite right. So that was wonderful question and session with the audience. Faculty here, please.
Yeah, I have, Dr. Agarwal, if you are okay, I have a few questions for Pravas.
Yeah. Of course.
Pravas, good talk. Thank you very much for giving us an overview in the real world. My few questions are, one is, what is your trigger in your follow-up for considering a bone marrow transplant in patients who are in the intermediate risk? High risk, no debate. In intermediate risk, what's your triggers which makes you say, okay, partner, I'm going, and you counsel the patient?
So for intermediate risk patients where we do not have any other info, so let us say that I have got an intermediate risk patient who is normal karyotype, and also the NGS has not given out any information. The MRD at the end of induction has been negative, and the person has done well, has completed 3 consolidation. I give 3 consolidation cycles with high dose cytarabine. Thereafter, I follow up these patients every month. So I ask them to come to me with a complete hemogram every month, and I do a physical examination at least for the first 6 months. Thereafter, I do it every 2 to 3 months. And at any time point, if there are any changes, is when I would intervene. So this is for intermediate risk, where I do not have any other information.
Thank you. Role for autologous bone marrow transplantation in the intermediate group.
So there is data, sir, and even if you look at the ICMR guidelines in intermediate risk, again for those patients who do not have any adverse cytogenetics on NGS, your autologous stem cell transplant might be a good consolidation strategy. I have not yet used autologous transplant in this kind of a setting. In intermediate risk group without any other adverse factors, I use 3 cycles of high dose cytarabine as consolidation.
You know, you'll be happy to know in 2002 to 2006, we did 12 autologous published in ISTM journal, wherein out of the 12, 7 are alive even today. So,
Yes,
and the armed forces, so we follow them up. So just a last question. What is the oldest age you will consider performance status is good for transplantation in AML, where you think he needs a transplant?
So I keep a target of 60 years of age. So between 55 to 60, I usually take them up for a transplant if they are fit physically. 60 to 65, I have tried, sir, but my outcomes have not been very good. Even though the transplant has gone out without a hitch, subsequently, if they had either GVHD or they are prone to infections, my outcomes have not been very great. So that is why 60 plus, I do not use. I'm not such a great fan of doing allogenic stem cell transplants.
There are so many molecules, like Dr. Agarwal said, I said. When do you use bridging in an older patient, to overcome having to give 3 HiDACs, and you think he needs a transplant, and you use a bridging with one of the 2 combination of targeted agent like venetoclax or others after induction, successful induction?
Hello.
Yeah, we can hear you.
Yeah, okay. No, I lost Dr. Velu Nair for a second out there.
Velu,
but what I understand is he wants to know whether what do I do in my older patients. So somebody
no, not older patients.
No. Oh, sir,
Where do you use bridging therapy, which is not HiDAC, after a successful induction in the older patients to take him for a RIC or a transplant when you think he deserves a transplant?
So let me get this clear, sir. So we have got somebody through induction very well. And now I need to consolidate with a high dose cytarabine, or I plan for a transplant. But now I want to bridge. So such a situation would only arise if he had a rough induction and he's still not recovered completely physically or mentally from the induction. He is still in remission and would like to buy, and both the patient and me would like to buy some time. So that would be one place where I would use a bridging. I'm not a fan of the so-called generic venetoclax, but then I would like to use at least an azacitidine at that point of time. If he could afford a venetoclax, well and good, so we could even use that as a combination, and perhaps even that oral azacitidine that has now come up till the time that he could be taken up for a transplant.
Thank you.
Thank you, sir.
Thank you, Dr. Nair, for those wonderful questions. Anybody else? We have time. Okay, so if there are no questions, Pravas, thank you very much for putting up that wonderful lecture and participating in this lovely Q&A session.
Thank you.
We move on to the part 2 of today's webinar. Once again, those of you who have logged in late, this idea of 5 days webinar on 5 diseases was conceived by Dr. Reddy's, executed by Mumbai Hematology Group, and was called here in review because we are covering essentially what was presented and published during last 9 to 10 months of 2021. Dr. Reddy's is coming up with this wonderful molecule, which all of you will be very proud of and will be discussed extensively by Dr. Bhausab Bagal this evening, oral azacitidine. Now we move on to the part 2, that is panel discussion. And the panel discussion is treating AML in 2021 beyond 7+3. So the title is very exciting, and you've got a very exciting person to moderate it. You've got Dr. Vikram Matthews, Associate Director, Professor of Clinical Hematology, Department of Hematology, CMC Vellore. Panelists are also equally exciting. We've got Dr. Sachin Gupta, Associate Director, Consultant Medical Oncologist and Hemato-Oncologist at Max Super Specialty Hospital, Mohali. Dr. Sriraj Vasudevan, Consultant Hematologist, Hemato-Oncologist at Amala Institute of Medical Sciences, Thrissur. We've got Dr. Anshul Gupta, Associate Professor, Department of Hematology at SGPGI, Lucknow. We got Dr. Shrikant M, Senior Consultant Hematologist, Apollo Cancer Institute, Apollo Main Hospital, Chennai. We got Dr. Ragesh Radhakrishnan Nair, Director, Department of Hemato-Oncology, Bone Marrow Transplant, Maitra Hospital, Calicut, Kerala. We got Dr. Raja, Director of Medical Oncology, Apollo Hospitals, Chennai. And with that, I invite Dr. Vikram Matthews to take over.
Thank you, sir. I hope you can hear me.
Yeah.
Okay. I got it. Please tell me if you can see my slides.
Yes.
Okay. So today's topic is treatment of AML beyond 7-3. So I think it's impossible to get away without going through a little bit of the basics before we get into this very exciting area. Thank you, sir, first, and Dr. Reddy's for inviting me for this. Privileged to be here as always. And I want to thank the panelists. Dr. Agarwal has already introduced all of them, all eminent in their own rights. So this discussion is, actually, I've not shared much with the panelists. It's basically to try and put a real world twist to how we face our challenges. And our challenges are fairly unique in AML, as all of us know. So I hope in the next 30 minutes to walk us through some of these challenges, some of the caveats of diagnosis and risk stratification, especially in the context of recent drug approvals. How relevant are these recent drug approvals in India? Everybody's talking about venetoclax and azacitidine plus venetoclax, so we'll spend some time on it, and strategies to address early mortality. What we won't discuss is checkpoint inhibitors, bispecific CARs, and NKs, and other immunotherapy strategies. There's a lot of molecules that have recently been approved. For the most part, they are a theoretical discussion and we'll stay out of it. And some of them have not shown as much promise as we expected. Besides, and we also won't touch too much on maintenance because there's a separate talk that's going to be addressed on maintenance therapy. So I'm going to open it out to the panelists and opinion on current challenges. What are the challenges you faced in diagnosing AML? Access to, when we talk about all these molecular tools and targeted therapy, these are kind of important. So Sachin, can you just tell me your real world experience with access to all these tools? I know you live in you stay in a big metro, so you probably don't have too much access, but I'd like you to kind of broaden the horizon in terms of what you think is an average oncologist around the country.
Yeah, thank you, sir. As we know that we have latest NGS as well as FISH techniques to evaluate the genetic studies for these patients. So we try to get all these tests done wherever possible. So I usually order for a conventional cytogenetics and a AML FISH panel and NGS panel wherever possible. So cost does become a constraint. But I do counsel my patient that these tests need to be done for a better prognostication and for making a better plan for treatment for the patient.
Thank you. I kind of agree with them.
And so we do lose many patients because of the cost.
Yeah, so you don't do this for many patients. But I take on one point that you said, if you're going to truly treat an AML and go the whole way, I think these tests are important to make decisions today. And so I think it's very important right up front to decide, are you really going to go full intent curative therapy? I don't think there's any point in just doing an induction and stopping. So some data on that, I'm not going to go through this. A lot of it is our data. I just want to highlight something about age, and I'm sure all the panelists will agree with me. A lot of the patients that we diagnose are fairly young compared to what you see in the literature. of the median age in the US, for example, showed on this panel over here is about 67 years. Most of our tertiary centers, the patients we see are much younger, and the distribution is almost a decade or more younger in our population. There's not much difference at the molecular levels. And again, this has been validated in our center and also 3,840 patients over 9 centers. Only a fraction of patients actually get standard of care therapy. In our center, it was about 30%. It may be more of those who are diagnosed AML. And we have serious problems with microbiological infections. So I'll open it out actually to all the panelists and to ask anybody, do they have any particular concerns about the type of infections that they see and the challenges that they have with them? Sriraj, you want to start off? This is some of our own data. I'm just curious if you all have any different experiences. So at our center, in 67 patients who have culture positivity, 30% are gram negative. 30% of the gram negative are carbapenem resistant Enterobacteriaceae. And these patients don't do very well, especially if they pick up these infections very early. Sriraj, are you there? I'm not sure. If
yes, sir. I am here. Yes, sir, I am
okay.
here.
Sorry.
Sir, yes, sir. My center, sir, the culture positivity rate is not that high like your slide 65. It comes around 30 to 40% culture positivity. Majority are gram-negative bacilli as in CMC data. We have quite a high number of CRO infections, and we don't have this gene expert to assess the sensitivity of drug. So we kind of find it really difficult whether to give ceftazidime-avibactam or whether to go for a combination of meropenem colistin. That is our
Yeah, I think Sriraj, we are frozen, but I think those are the real challenges for many centers, with the exception. Sriraj, you froze in between, but I
I'm here.
echoed your statements. Yeah,
I'm hearing, sir. Yeah, yes, sir.
Yeah, that many centers have that culture positivity rates are poor. Microbiology support may not always be there. It's sometimes a challenge, but many centers increasingly have, and when they do have, this is a serious problem. And this has been replicated in many centers. This is data from THMH, again saying a high incidence of multi-drug resistance infection, as has been seen in JIPMA, where they again see about 30% documented multi-drug resistance infections during induction. So in terms of risk stratification, Anshul, do you want to talk about risk stratification in AML and its relevance?
Yeah, good evening, sir.
Good evening, Anshul.
Am I audible?
Yes, you are clearly audible.
Yeah, so in AML, when we risk stratify our patients, our risk stratification is based on 2 factors. One is the molecular profile as suggested by the ELN, and the second one is the patient-related risk factors, which are equally important. I feel like age, the performance status, and any pre-existing infections, life-threatening infections like fungal infections or any bacterial infections when the patient comes to us for treatment. So these are equally important because that determines the type of therapy which we are giving, irrespective of the molecular mutation which the patient is having. So both the factors we take into consideration before deciding the therapy for these patients.
Thanks, Anshul. I think Anshul raised a very important point. While we all tend to focus on the molecular, and I think we all kind of recognize it, age and performance status, whatever the cause for the deterioration performance status, are important factors. This is an old data, but nothing has changed. I just want to highlight what's in the box. If you are more than 65 years of age and you have a performance score more than 2, ECOG performance score more than 2, your mortality, and please remember, these are all in the setting of clinical studies for the most part, is still 50%. So in the real world, you can expect the mortality to be much higher. So age is a very important factor, and above 55, 60, I would say that honestly, there's not been much progress in AML in terms of long-term outcome. So we must be careful when we induce therapy. Going to the standard risk stratifications, can I ask Srikant, if you're there, to just walk us through? I'm just going to take the ELN to illustrate a few points. Can you just walk us through the risk stratification, Srikant?
Yeah, so we, hi, good evening, everyone. So we have like 3 factors: favorable, intermediate, and adverse, So I think with the advent of new molecules, now I think we are in a position to identify whether we could use them. I think so. That is one thing. Say, for example, as you said, if patient is old and has some high risk factors, then I think we know just chemotherapy alone is not enough to get a durable remission. And again, if you are a good risk, then we know that we can get away with just 4 cycles of treatment. Again, in standard risk that is divided, then we need the molecular stratification to further subdivide whether we are going to need a transplant as consolidation or not. Then again, with the advent of new molecules, it's important to know whether we have a upfront FLT3 mutated AML where we are able to offer a FLT3 mutation mutated inhibitor. So like FLT3 inhibitor, for example. Then again, the next question is, with the IDH inhibitors, I don't think we have the facility to use them yet, So again, the Vioxx and things again are not available for us freely. Now, with the advent of venetoclax again, I think that changes the paradigm a little bit is what I feel, because we can see now venetoclax is overcoming the high-risk target mutations and the curves are almost identical. So that is my understanding as far as what I have understood. Even though we do all the mutations, how far we are able to use them currently in our context with the availability of new molecules
is a challenge. Thanks, Shrikant. So I'll talk a little bit about the need for rapid diagnosis of good risk and high risk for very different reasons, and I'll come to that. We ourselves have not implemented this immediately, and so turnaround times for some of these tests are important, and I'll talk a little bit about that. But before we go on, there are some caveats, and one is that AML is often an oligoclonal disease. So some of these molecular tests that we use are mostly qualitative. They're not quantitative. So they're either positive or negative. So one must be careful not to interpret that every cell has that mutation. I think that's important. Second is, with all these targeted molecules available to us, how long can one wait for the results? Because you have to start therapy with the targeted agents. So that's another question that we need to answer. And are these molecular tests relevant or needed to start treatment? So I'll just request Dr. Ragesh to comment on the oligoclonal nature of AML and its impact on diagnosis. Ragesh, if you're there.
Yes, sir. So as AML, some of the mutations are oncogenic and some arise over a period of time. So at different points of time, those mutations may be different. So at this point, maybe somebody might have caught maybe an IDH mutation. Subsequently, some other mutation may overrun those mutation, and some driver mutation might take place, and that may be the major clone.
Right. Thanks. So this fish plot, for example, the patient is diagnosed at this point. He actually has 4 sets of mutations. So just imagine the purple was an NPM1 mutation. When you see NPM1 positive, you should not think every cell has NPM1. So even if you had the most perfect targeted therapy for NPM1, you're not going to get rid of every blast. You're actually getting rid of a proportion of blasts. And also when you monitor NPM1, you must keep in mind that when NPM1 disappears, doesn't mean to say leukemia actually disappeared, because it may actually represent only a subclone. And unless you do an NGS with a variant allele frequency, you actually won't know this, you won't have this information. I think that's important. With regards to FLT3 mutation, Ragesh, yes, what is the method that you should use? Because again, often some people just do NGS and don't do anything else, and there are some risks with that.
So I, in my practice, use the fragment analysis because that is quite sensitive, and also it gives the variant allele ratios. So whether it is more than 0.5 or not, that information is achieved by fragment analysis. So that is a method and it is a decent turnaround time of around 7 days from the center we get it done.
Sure.
So
I think the key points, my apologies to the panelists, I'm just going to break in between if you don't mind. The PCR based is preferred because NGS can pick up, but it can miss FLT3 ITD mutations. And ITD should preferably be done with a gene scan, so you get the allelic ratio, and you need to generate the allelic ratio. What about time from diagnosis to starting treatment?
Sir, can I interject? Sorry.
Yes, please. Please do.
Sir, I recently had an experience of a AML young patient.
Yeah.
And in which the FLT3 was picked up on NGS. but
The
not on
TKD or ITD?
ITD.
Okay, so I'll defer that to if there's an expert on molecular. Generally, NGS is not the choice for picking up ITD. We call them indels, insertions and deletions are not well picked up by NGS, as are reciprocal translocations, for example, which is why often you have to complement your cytogenetics and NGS, and you should not rely only on NGS, but you can definitely talk to an expert on that. This is my understanding of NGS. So you have to be a little careful when you say NGS is negative and does not have FLT3 ITD. You know, if it did pick it up and if they have methodologies to pick it up with new bioinformatic pipelines, well and good, but one must be cautious. So are we going to wait for these tests? Are you going to wait for the FLT3? Are you going to wait for the IDH1? Even if you had access to these therapies, how long can you wait? Dr. Raja, in your practice, do you wait for all these molecular results to come across before you start therapy?
So thank you, sir, for asking me that question. In practice, in general, I don't think we wait for all these molecular analysis to turn in. And as was mentioned, we look at initial stabilization of the patient, that the clinical and the way they present, and organs, various organs and infections. Those are the real issues that you tackle before you decide to induce them.
Yeah.
But as the diagnostics are improving, and now I'm just going back to one of your old questions. I mean, you talked about the country as a whole.
Yes.
What I see I'm sure you know better than me, but what I see over the past 2.5 decades or 3 decades is that the diagnostics are now widely available to everyone and anyone. You would agree that
much more
only
penetration.
Good hospitals, tertiary care hospitals, even a smaller center is capable of sending it to some laboratories, let us say, without naming anyone.
Yes.
And most of them are turning out to have some standard, or most of them are standards. So the turnaround time has been now, I would say, many of them do walk in with all these investigations. So, they have gone around for a week or two and come with all these things. So that is another context. Yeah. But having said that, in practice, we don't wait for all these molecular to come to begin the induction in general, even though I'm aware of some of the data set that would argue that
you should wait.
In a well-stabilized patient, rushing and starting would not mean anything. That's what. But again, if you look at those data critically, majority of them have started the therapy. Majority, I would say 90% of them have already started the treatment within a reasonable time frame of 1 week or even less than 1 week or something. So
Absolutely.
1 week. So how to take that data when 90% of them were already treated in what we consider as an optimal time?
Yeah. So this is data from the German study group, 4,700 patients, and they're just pushing a point across. Waiting up to 15 days did not change the survival in all patients less than 60 and more than 60. Okay, I would agree with Dr. Raja. We certainly don't wait, and one must be very careful about extrapolating this kind of data to our own population. It may be very different. We have a very different scenario. As you said, many people have already waited for a long time before they actually come and present themselves to you. But the data is what the data is in this data.
Sir, I have a doubt. Sir,
yes,
I have
please.
a doubt.
Please.
Sir, we come across patients like 50-year-old patients with AML. We start induction chemotherapy. By day 8, the cytogenetics came as monosomy 8 or monosomy 7. MDS characteristic changes.
Yes.
And these patients, in my practice or in my experience, they tolerate very poorly in induction chemotherapy. So in this case, if we waited till the cytogenetics report, should we change the therapy to an hypomobility agent-based therapy?
Right. So that's why I put that stat fish. We've not implemented it, but conceptually, if you picked up complex cytogenetics, monosomy 7, TP53 mutations, you could seriously say that maybe we could have avoided the 7-3 because the response rates with them are quite poor. But the reality is, just like you said, often we get this almost on day 14, 15 of the therapy, and then there's really not much we can do. So the stat fish for picking up co-binding factor leukemias and high risk is not standard of care, but I think it may evolve to a point where if you identify some of them, The point is, in the good risk, in the co-binding factor leukemias, you will add gemcitabine or zagomycin. It's a theory right now for us, and I'll give you some data. And in the very adverse risk group, you may actually avoid the 7-3 induction. So that's the point taken.
So I would also like to make one point. So if you wait, suppose somebody is 55, 58 years old, sometimes we are confused. They look fit and we want to give 3+7 versus as a when.
Yeah.
So if we wait, sometimes if we find we have got sometimes core binding factor leukemias, we would go on to give 3+7. So
yes.
I think waiting might have some advantage in certain situations.
I think in certain situations, I'd be very cautious. I would not go and recommend it and put myself out on a limb. I think you have to play it very carefully
Right.
because I think in India, still starting treatment early can make a difference for some patients. So with intensive therapy, does anybody in the panel use 90 milligrams per meter squared of amphicycline based on this published data?
We had used previously, but our treatment-related mortality and infections were higher. So we went back to 60.
Okay, so I'm just going to go very rapidly through this. And I want to highlight a key point, Ragesh, that you said. If you look at this data, there was about a 5% improvement in survival. But the reality for us in India, which is why our own data is so important, our problem is induction mortality. In this particular study, there was no increase in mortality. But for us, those small changes could translate to improvement in increased mortality. So, and we also have data subsequently saying that 60 milligrams per meter squared is as good as 90 milligrams per meter squared. And I think most people are using this. In ITD, FLT3 ITD, both the ECOG study and the MRC suggests that 90 milligrams per meter squared is better for FLT3 ITD, but we don't use it. I'm just putting out the data over there. And this brings me to a point about very good randomized controlled trial data, which is there, but we don't follow because we recognize that this may not work. So if you look at the UK AML 15 trial, the best induction was FLAG-IDA into 2, followed by intermediate dose cytosine. I don't think we could do this in India. So one has to be careful in India, and most of us know our own data, know our own patients better. So we should not necessarily have to jump and follow published data because they got fantastic results, which may not necessarily apply to us.
So I have a doubt for you to ask to you.
Yes, please.
In your data in CMC, when you have been for many years analyzing, did you find differences in the CR and the PFS between using 45 per meter square versus 60?
I've not actually looked at that data, to be honest with you. For the longest time, we've been using 60 and we never changed to 90. So I really don't have the previous data to the 45.
So if I may comment, sir.
Yes, please.
I mean,
I would request Dr. Agarwal to just tell me when there's 5-7 minutes left.
I will do that.
Okay.
See, the 90 publication is actually, as you pointed out, is a comparison between 45 and 90.
Yes,
and
yes.
The UK data showed that there is
any difference. Yeah.
60 and 90. And definitely nowhere, I don't think there is any data that clearly showed 90 to be superior to 60. I'm not sure whether even in, And again,
even the swab data did not support that.
And again, there is no compare. I think we can infer that 45 is probably inferior and 90 is not superior, and therefore I think it may be wise to stick to what we are routinely doing.
Yes, I agree with you. Okay, we're going to move rapidly. There's a whole lot of molecules. We can't possibly cover all of them. I just want to ask you, Dr. Sachin, how relevant are all these molecules to us?
Sir, I think they will be relevant subsequently. Right now, midostaurin is one thing which we are actually able to use.
Yes.
And that is convenient also because by the time it has to be used, we usually have the report. So that is how the usage has been devised into the protocols.
Correct.
So I have experience of using midostaurin and also venetoclax in elderly and unfit patients. But rest of the things are still, I have not personally used.
It's a lot of theory. Thanks. I think almost everybody will uniformly agree with Dr. Sachin has said. It's midostaurin and venetoclax, which most of us have experience with. There's a whole lot of new molecules. I'm not even going to touch on them. And what we hope is with these multiple molecules since 2017 that are coming, with better permutations and combinations and scheduling, we will reach what has been done with AML by using the same drugs with optimal dosing and scheduling. Now, I'll talk a little bit about the role of gemtuzumab because of shortage of time in the co-binding factor leukemias, why it may become in the future very important to rapidly diagnose inversion 16 and A21. And that's because of this data from Alpha 0701. It's not a standard recommendation, but the data is very interesting. When they did a meta-analysis of 5 studies, the randomized trials showed a difference and an improvement in event-free survival and overall survival. But a meta-analysis of almost 3,000 patients showed that this benefit was almost a 20-point improvement in the good risk patients, not in the intermediate risk or the high risk. So there may be a role for low-dose gemtuzumab 137 given in patients with co-binding factor leukemia, surprisingly. So in the co-binding factor leukemias, there may be a role for gemtuzumab, but in the high risk, there may be a role for avoiding 7-3 by rapidly diagnosing. So this is where, to some extent, the data is going. Dr. Sriraj, what's your concern with any of these new drugs that you add, either as a triplicate or etc., with regards to neutropenia, duration of neutropenia?
I think most of these drugs are quite toxic, you see, and I think you're increasing the chances of infection and especially CRE infections as well. And I think that's the major cause of concern, especially with venetoclax. We are seeing a lot of cytopenias and infection, and again, in combining with azacitidine as well, so I think the dosing and scheduling is one of the big concerns, and also when to step back from the venetoclax dosing as well. It's more or less, that's the problem what we are we are facing.
So I think in India, we have to be very conscious about duration of neutropenia because it does translate to mortality in our country, while it may be morbidity in the West, So the midostaurin data is reassuring because actually in the induction with day 8, there was no difference in the neutropenia compared to the control group, okay? But if you look at the Vioxx data, it's not shown over here, while it was superior, the median duration of neutropenia was above 30 days, almost 35 days in induction. But interestingly, it did not translate to increased infection. And the explanation given for that is there is less off-target side effect on the mucosa, etc. So there's less transmigration of bacteria from the gut, etc., causing infections. But we need to see what this increased duration of neutropenia with this drug will be in India. We've not used it. The other molecules, AZA and VEN, as you said, and especially newer combinations can have prolonged neutropenia, and we'll touch on them a little bit. Data with venetoclax, any role as a single agent, Dr. Anshul?
I feel, sir, that venetoclax as a single agent really don't have much role, but it has got a fantastic role when it is combined with either AZA or destabine. So definitely in elderly patients more than 60 who are not transplant eligible, and in fact in some patients who are young but unfit to receive intensive chemotherapy because of comorbidities or some infections. So this can really be a game changer because the remission rate and the counts recovery is quite fast after around 1 month, once first cycle only.
Yeah, so I just wanted to highlight that there's almost no role for it as a single agent at any stage, either newly diagnosed or relapsed refractory. So don't throw this around just for the sake that it's available. It's not going to work. And everybody is familiar with this data. I'm not going to touch on this as a citing with low-dose cytosine, as a citing with venetoclax, showing great promise. In fact, the concern is everybody is moving too fast into AZA-VEN, and even in a multi-consultant department like ours, it's sometimes very difficult for two people to agree that the patient is not fit for 7-3. There'll always be a difference of opinion. But
sir, can I interject, sir?
Yes, please, Sachin, please do.
Maybe it's important for everybody also.
Yes.
So how are we using venetoclax and what dose? And are we combining with fluconazole or voriconazole to reduce the actual dose to save cost? Are other people doing that?
We'll come to that in a minute. We'll come to that in a minute. Yeah. Okay, 2 slides away. So I just want to highlight that the studies were done in a very controlled setting, and it was so-called unfit patients. That definition is a little loose. So one has to be careful. So coming to the practical strategies, which you exactly said, Sachin, I think the strategy for us is to always combine it with posaconazole. And therefore, at least at our center, I'm happy to listen to other the panelists. We never go more than 100 milligrams in AML. Neither do we do a ramp-up strategy. We have posaconazole and we start with 100 milligrams, and that's all most of our patients can afford, and we stay on that when we have to do it. So these are the other practical considerations. You don't go with ASA when in patients who are unfit, like chemotherapy in ALL, bang, 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 on time, day 28. If the patient is not doing well, he's got cytopenia, if his marrow is hypercellular, you just delay the treatment. You give growth factors. If he's got blasts, of course, you can give the second cycle. If not, you give growth factors and you step back and wait for them to recover. And if there is recurrent cytopenia, have no hesitation in reducing the frequency of the venetoclax from 21 days to 7 days, or 14 days, and then 7 days. Or second step, reduce the dose of the hypomethylating agent as well by 50%. Hepatic impairment, 50% dose reduction. GFR less than 30 ml, probably avoid. Be very careful about using other CYP3 inhibitors because they can also increase the levels when you combine. And a few CYP3 inducers can actually reduce the levels, like the rifampicin and anti-TB drugs, for example.
Sir,
yes, please.
Have you used the 10 days decitabine with the venetoclax?
No, we've used predominantly the ASA plus Ven. But whatever data is available, Rakesh, from whatever I can see, there's really not much to choose between the two,
I mean, the 10 days decitabine with venetoclax, sir.
Yeah, I've not seen any data to suggest that it is superior or that the toxicity is more. But
I think some data is probably coming up that MRD rates are more in 10-day 10-day decitabine plus venetoclax.
Yeah, but there may be a price to pay for that, and I'll come to that because there's this very interesting data that is increasingly being pushed about FLAG-IDA plus Ven in induction in newly diagnosed patients. This study is on relapsed and refractory and newly diagnosed patients. Just one word of caution. Very prolonged neutropenia. We have used FLAG-Ven in relapsed refractory patients as an induction and a bridge to transplant. We have got patients through with fairly good responses, but the duration of neutropenia is a little scary. And in this particular study, they had to multiple times stop the study and readjust the dose of cytosine. So if you're using FLAG with Ven by any chance for any indication, don't use the standard dose of cytosine. Please look up the data. You have to back off on the cytosine dose when you're combining it in this combination with venetoclax. I would
What's
also.
the mortality rate in relapsed refractory FLAG-IDA?
In this particular publication, that's what I'm saying. It's very good. The response rates is very good and the survivals. But our own experiences, the duration of neutropenia is very long, in patients. Response rates may be good. So your supportive care and the supportive care costs are going to be quite high. It's not just the cost of the drug.
Sir, will you be using decitabine with venetoclax?
Yes. We use azacitidine plus venetoclax, but I would not fight if anybody uses decitabine with venetoclax for newly diagnosed patients.
Okay.
The question is, which patient would you use as a Ven in your setting? I'm happy to listen to anybody on this. Any thoughts on in your own practice? I'm talking about a young, fit patient. I'm not talking about the elderly, the unfit, where there is no question about going with this versus the 7-3. I'm talking about a relatively younger patient or a patient sitting on the fence. Does anybody have thoughts on how to decide?
I had recently a patient who was in her early 20s actually, and she was quite less than 50 kgs, and she was very fragile as well. So my concern was whether to go and give her the 3+7 induction. So I think after long discussions, we actually went to giving her azacitidine venetoclax, and then I gave her only for first 21 days, and then after that, still she was cytopenic. I think second cycle I gave her venetoclax for 14 days, and that's again I just wanted to check with you whether second cycle would you just go the full 28 or then after platelets.
I wouldn't. It's exactly what I said. If you have cytopenia and you have a hypercellular marrow with no blast, first thing you do is actually delay the treatment by giving growth factors and waiting for some time for the count to recover, even after cycle 1 in an unfit patient. But you don't give ASA and when
she was still having disease
no
actually.
If there's disease, it's it changes the equation completely.
Yeah. she still had disease, so we gave her only 2 weeks of it, you see. So, and then surprisingly, after cycle 2, she went into CR actually.
Yeah. An average is about 1.2 cycles is for achieving remission. So she's probably one of those patients. So the simple answer to this is there is nobody knows the answer to this exactly. You know, there is always the subjectivity of what you will feel patient may not tolerate, another person will feel will tolerate. So there are some scoring systems, but we really need to work to generate a scoring system that is regionally, loco-regionally relevant. So it's very difficult to take these scoring systems that are available away outside and predict mortality in our own patients. So I would also urge caution because I'm just showing you some of our own transplant data, people who have gone through standard induction, young adults with transplant in CR1, where they're eligible for transplant in CR1. The cure rates are very good, very mature data. You're looking at 60, 70%. So this tendency to straight away de-escalate therapy to azaven, you know, etc., in young patients who can afford, etc., I would view with a little bit of caution. I'll be the happiest person if there's a phase 3 trial that establishes that azaven is the standard of care for young fit patients. But I think at this point in time, we are not there yet. And it becomes more important that you have good induction because MRD negativity prior to transplant is a very important factor. And whatever data is available right now, except what Ragesh was saying, the MRD rates with the conventional azaven is far less than with a conventional 7-3 induction at this point in time.
Sir, I have one doubt.
Yes, please.
When you use MFC for MRD or NGS or whatever be the parameter, when you use azaven or decitaven, what are the timelines of your testing and how do you interpret whether the patient has to be taken up for transplant? I mean, if he's a 50 years old chap who is
So the answer is that ideally we should do a marrow at day 28 of the first cycle. The second one is not very clear whether you should do it after the second or the third cycle. But if you're basically not showing any response by 4 cycles, we know that you should probably stop and not continue with the azaven.
I mean, sir, not that, sir. What I was asking, suppose you are using azaven, most of the data for MRD utility for transplants have been from classical induction therapies, 3+7 and all.
Yes.
When you use aza plus ven, what are the timelines you decide that, okay, he has MRD positive, intermediate risk group, has a haplo match only, there is no mud match, there is no mud donor or an MSD, only a haplo donor is there, and he is around 50 years old. MRD, when would you consider transplant? In 3+7, immediately after induction, you can say, oh, he's MRD positive, we can take up. But azaven
negative. No, the point Ragesh I'm making is, if you are what this graph shows, I'm sorry, I'm not able to go through in detail. If you are MRD positive or have active disease at the end of a conventional 7-3 induction, your outcome is equally bad compared to those who are MRD negative. Okay? So in azaven, unless you achieved hematological remission, there is no point doing MRD. Okay?
I mean,
Step one.
I mean somebody who achieved hematological remission, sir. In that
somebody who's achieved hematological remission, if he has not achieved MRD negative,
fine.
I would think twice about taking them up for an allogeneic transplant with MRD positivity. That's the point I'm trying to make with this slide.
Okay, right, sir.
Okay, and the rate of that conversion in a young fit patient is probably at this state, again, we don't have phase 3 randomized control data, is probably better with a conventional induction. So that's the only point that I have to make, that I put out over there.
Vikram, you can take 5 more minutes. And then you can take the question from the audience.
Okay. So supportive care issues.
If I can ask you one question.
Yeah, Dr. Raja.
As Dr. Ragesh was asking, and MRD is one of the selection criteria for eligibility for transplant. How would you explain that in a younger patient, wherein your data and many other data show that the MRD negative or MRD positive is actually equal to active disease, so you have clearly shown the outcomes. Whereas in patients, elderly patients, MRD negative, if they achieve, you can actually de-escalate rather than pushing them forward. So that is one signal. The other thing is, whereas in acute lymphoblastic leukemias, you think that you need to compulsorily transplant them when they are MRD positive, whereas in AML data shows that MRD negative are the best subgroup to be taken in first CR. So how do we explain all these things put together as MRD as a selection criteria when we choose patients?
So some of this is just clinical trial data. It's very difficult to biologically equate ALL and AML. And the ALL data, I'd be very careful. You must interpret it as what the data shows is in pediatric data, nobody has shown that if you transplant, your outcomes will definitely improve. Okay, and I'm talking about more than 1% positive. I'm not talking about the borderline. The borderline, there's a difference in the survival curve. How much intensification will improve? We know that intensification of therapy will improve. But if you're not in hematological remission at the end of induction, there is very little data that says that transplant will actually make a dramatic improvement in outcome. So a lot of data with transplant sometimes is extrapolation, not actually based on very good clinical data. That it's like relapse refractory ALL. Yes, we do transplant them. But if you take an early relapse refractory ALL and you do allogeneic transplant, believe me, the outcome is dismally poor. But we still have the sense that transplant is still a superior therapy in certain situations, not necessarily always data driven.
So my second question to you is that staying on to your topic, and how do we make a difference today in India over 3+7? And as we heard from everyone, all of us are now happy to take up midostaurin. I have patients who are on maintenance for nearly 8 months, 1 year. So I see, and then patients who didn't respond to a single 3+7 when I added midostaurin when we found out there. So I'm totally sold on the concept and the drug and how do we manage. So I have few patients on that. And again, the venetoclax plus any one of the hypomethylated, whatever be your choice, I'm convinced on their utility in elderly patients or in anybody's mind, fragile patients, whatever. And even
I
in relapse
completely
patients.
agree with you. I completely agree with you.
The third important data that you showed is actually the gemtuzumab. Way back in, I'm sure you will, way back when it was introduced in 2000, we were one of the earliest, we jumped onto it and we really burnt our finger. That was 9 milligram and
dose was different.
Dose was different and all that. Yeah. One. Now that we have generics also have or about here and then this convenient 1,473 milligram. So don't you think that this is now a much more amenable drug which will make a
No, it's a much more amenable drug. But our problem is
what is your
it's just not available and it's very expensive. It takes so long to get it, even after you have to import it against a named person import. So it's just logistically a nightmare. So I think if it comes in, it will be a very good addendum to the co-binding factor leukemia.
Thank you.
Okay, so I'm just going to go through the supportive care very rapidly. Role of prophylactic antibiotics, it's recommended, but we have to be careful because we can't use quinolines in India as prophylaxis. It will be an insult to the bugs in India. So we really don't know what to do for that. There is a role for prophylactic antifungals. There's data with posaconazole. Growth factors, we use regularly in induction, though it's not recommended in EL guidelines because consistently it reduces the duration of neutropenia, but it does not change the total mortality by adding GCSF. Appropriate antibiotics and very rapid and early intervention of febrile neutropenia is, I think, really the cornerstone. Antifungals and antibiotics. So your team has to be very good. It's not about individuals. There's a whole area about buffies and granulocyte infusions. I think there is a role for, especially in the context of multi-drug resistance infections, not evidence-based, but I think people are increasingly using it. I think we'll stop here. I thank all the panelists and my apologies to have to rush through, but this is a large topic.
But I have one doubt. How will you place the maintenance hypomethylating agents?
So I didn't want to touch that topic because there's a whole talk coming up on it. I think there is an increased role of maintenance therapy in AML that's being revisited, and the maintenance and the type of maintenance to a large extent will be dictated by the molecular diagnosis that is there at the onset.
Sir, in your practice, I had one question. Somebody post-induction is in remission, but MRD positive, intermediate risk, has a matched sibling donor. What action would you take to convert that MRD positive into negative, or would you directly transplant?
Yeah, so we would, at this point in time, we would give the data, both retrospective data, the EBMT and the ASBMT data in the pre-MRD period was that there is no benefit of consolidation prior to an allogeneic stem cell transplantation. But we would attempt today, if we had MRD positive at the end of induction, to give one HiDAC to see if we can attempt to convert to MRD negative. And failing that, we would just proceed with an allogeneic stem cell transplantation. With the exception of the blinatumomab data, there is very little data that MRD positive conversion to MRD negative improves outcome. So MRD positive may just be bad biology, which may not change necessarily. We don't have the answer to that question.
Professor Agarwal, allow us to have one last question to Sir. MRD, can you qualify on what
multi-parameter flow cytometry?
Is it only on the flow cytometry you are talking,
No.
or are you going to deep dive into something more and qualify your MRD?
I'm just going to talk about very hard data as multi-parameter flow cytometry, and the NPM1 data is fairly robust. Less than 3 log reduction, and the co-binding factor leukemia data is quite strong. Beyond that, the NGS, etc., is good, but we still don't have a good handle on how to interpret them in every case. Okay, sir, if you want to take the question, sir.
Yeah, Vikram, what is the major cause of mortality at your center? Relapse, infection, bleeding, or any other?
I would say it would still be infection.
Second question is, in acute infection and sepsis, can we delay the induction? And if yes, for how long?
That's a tough answer, sir. There's no straightforward answer. We do give antibiotics, but experiences, it's probably better in those patients to go with an AZA-VEN kind of therapy as early as possible, because it's very unusual for some of these infections to completely resolve when there's really no neutrophils on board. It's all blasts.
So that was the third question, whether we can use VEN AZA in presence of active infection.
You may have no choice. It will be a situation like that. Either treat or you will be stuck with no situation.
Last question is, if combination of VEN with AZA has failed, can I use VEN with low-dose cytosine albinocyte, and will it work?
The data is that if you have relapsed refractory after hypomethylating agent and VEN, any combination of them is a very, very poor outcome with a median survival of 2.4 months. So you're in a pretty bad situation if you've already failed hypomethylating agent plus VEN.
Thank you, Vikram, and thank you all the panelists for a great discussion. It was very enjoyable and very educative. Thank you.
Thank you so much. Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you. And we move to the third part of this webinar, which is a debate. So those of you who have logged in, I must tell you that the idea of this 5 days webinar on 5 subjects was conceived by Dr. Reddy's, executed by Mumbai Hematology Group, and called Year in Review Hematology 2021, so that we discuss what has been presented and published during these 8 to 9 months of 2021. Also, for some of you, it may be a news that oral azacitidine is going to be launched by Dr. Reddy's, and after Bhausaheb Bhagat's presentation, you will understand how important that molecule is going to be. And now we enter the debate. And the debate is, in acute myeloblastic leukemia, MRD assessment makes sense. You had some kind of exposure to this in the panel discussion, and now we will have 2 views on this. In favor, Dr. Ranjit Kumar Sahu, Associate Professor, Department of Medical Oncology, AIIMS, New Delhi, and against Dr. Soumya Mukherjee, who is Consultant Hematologist and Hemato-Oncologist at Apollo Hospital, Kolkata. So we begin with Dr. Ranjit Kumar Sahu in favor.
Sir, Dr. Sahu has not joined yet.
All right, so we can start straight away against the motion by Dr. Soumya.
Yeah, thank you, sir. Thank you, sir, for just I am going to share my screen. Yeah, is it visible, my slides?
Yes.
So, first of all, I thank Dr. Agarwal and MAJ, Mumbai Hematology Group, for giving me opportunity to say something about this. So today's topic is whether AML MRD assessment makes any sense. So it's a debate. I will tell against this motion. So as you all know, in any debate, the main motto is to reach any definitive solution, or whether this will help us to exactly identify what is the problem behind it. So before going into the details, I want to show these slides to you, because AML, how the disease progresses in AML. Basically, it is a heterogeneous disease, as already we discussed in the previous panel discussion. So from the diagnosis, here you can see there are a lot of blast cells, healthy stem cells, leukemic stem cells, it is there. And after the chemotherapy, induction or consolidation chemotherapy, still there may be some leftover cells, which comprises of the hematopoietic stem cells, few myeloid blasts, few AML blasts, and few therapy resistant AML blasts also. So ultimately, they will relapse. So basically, this is a disease progression of AML, and AML is a polyclonal disease, as you all know. It is oligoclonal disease. So there are a lot of mutations in numerous mutation in different patients, in different single patient also, and they highlights these two pictogram here. You can see they highlights the complex intra and inter-patient variation of the cell diversity. Each clone carries its own hierarchical. Here you can see each clone having their own hierarchical structures, and from those structures they give rise to different populations of cells, and ultimately there is mutations and there is leukemic stem cells, and they give rise to more mature leukemic stem cells. So at any point of time in AML, you will find different type of cells with different mutations, carrying different mutations. So it makes the task very difficult. CML is easy, APL is easy, but in AML, due to this variation, the MRD detection is really, really difficult. So as it is a heterogeneous disease. Now the question is, what is perfect MRD? Perfect MRD is the test where we can detect the smallest amount of leukemic blasts that are capable of causing the relapse, but it should be able to discriminate them from healthy cells, stem cells, or leukemic cells that is not capable of initiating relapse. In this beautiful article by Megan Othus, that is the statistics of MRD testing, measurable residual disease testing in AML especially, they give two important thoughts of this. If all MRD positive patients were deemed at high risk of relapse and received transplant, many persons would have received it with no possibility of benefit and substantial possibility of harm. In another part, if MRD negative persons were deemed low risk and they didn't receive any transplant, many would have relapsed. So this is it is a statistical, it is a very complex statistical model they have shown. There is a good number of patients, there is a chance of false positivity as well as a chance of false negativity. Here you can see these are lots of tools in our armamentarium to exactly detect the measurable residual disease, starting from the karyotyping, FISH, PCR, MFC, flow cytometry, NGS, and so on. And each of them having their different sensitivity, different advantages and disadvantages. So in our clinical practice, what we are now, current methods, what we are doing now is a multi-parameter flow cytometry and the molecular tests. Now, first I am telling about what are the pitfalls of multi-parameter flow cytometry. The relapse in good number of patients who are MRD negative, almost 25 to 30% of patients MRD negative still relapse. So this is the major drawback of all the MRD studies. So what is the explanation behind it? Both some technical problems and some biological reasons. First, that is the poor quality of the bone marrow sample. It is mixed with blood, diluted sample, contaminated with peripheral blood. And sometimes after chemotherapy, there is some population of regenerative cells which can cause some problem in detection of the flow cytometry because it is not yet standardized. And in fact, if you give the reports to 20 hematopathologists, there may be some problems in the reductions. And what are the technical problems? Yes. So before going into the technical problems, we have to understand how this technique MFC detects the MRD. So the detection relies on the detection of the antigen and physical abnormalities that are absent or infrequent in the cells. How we can detect? There are two ways. Number one is the LAIPs, that is the leukemia associated immunophenotype, where there is a cross lineage expression or overexpression or reduced or absent expression of the antigens. And number two is the DFN approach, that is the different from normal approach. So in this approach, what happens is a combination of antibodies they're using, and it is regardless of the LAIP, it identifies the events outside the maturation pattern of normal bone marrow cells. So there are two processes by which now MFC they are carrying on. So what are the problems? Number one, I have shown you the slides in the first or second slide, that is that there is a phenotypic shift. In the previous panel discussion, Dr. Vikram Matthews clearly showed that suppose the patient having NPM positive and ultimately when they relapse, that vanishes. There's some new clone. So there is some immunophenotypic shift is there. And LAIP and DFNs, which requires high levels of expression of the identification of the AML specific events. And third, but the most important point is the high level of expertise, especially in AML MRD. ALL is okay, but in AML MRD, their expertise is needed. And background noise because of some plasmacytic dendritic cell, masked cell, that can cause some problem in AML MRD. So next point, the molecular test, what we are using now, PCR-based NGS and digital droplet PCRs. These are the techniques now used for molecular MRD. And in this molecular MRD also, there are some problems. What are those? I'm giving some examples. Suppose WT1, we are monitoring those molecules if there is some mutation in those AML patient. This expression as a MRD marker is very controversial because there is a low sensitivity and specificity of the molecular assay. NPM1, that is, there are some robust data also for NPM1 AML, but this is also troublesome to some extent. There is a chance of several frameshift mutations, insertions, and this lack of information from in the diagnosis also creates a problem in future and in tracking of the disease. And a third point, there are a few DTA mutations. Collectively, they are known as DTA, DNMT3A, ASXL1, TET2. These mutations can be picked up by NGS, but these mutations are also positive in many aged patients also. And in more than 50 to 60% of AML patients also show this type of mutation. So they definitely have no prognostic role in MRD. So therefore, it is clear that NGS-based MRD assessment is hampered by the presence of this chip, clonal hematopoiesis and ancestral clones like this. Some mutations like FLT3 mutations, it's not stable and can become detectable or disappear when they relapse. So it is not recommended for FLT3 mutation. And the prognostic markers of IDH1 and IDH2 is not clear till date. So there, what are the confounding factors which causes false negative result? Some are patient or disease related factors, like these MRD targets are consistently present, not present in all AML cells. It is a heterogeneous distribution of the leukemic cells in the bone marrow. Relapsing tissue and chloroma is not possible if the sample size is too small. These causes false negative results. And sometimes in false positive results can happen if the follow-up time is too short, or some GFL effect, graft versus leukemia effect, and some sampling error, inadequate storing, shipping condition can cause problem, and sample contamination. So these are some confounding factors which causes false negative and false positive results also. Now moving into the clinical part, that is the most important part, because being a clinician, My first question is the presence of MRD at any time point prognostic for overall survival? Few studies which clearly showed that patients who had detectable MRD after induction, but ultimately became MRD negative after second consolidation, shows the same prognosis, those with MRD negative in 2 occasions. Number 2, in contrast, the initial clearance of MRD, but again it came back in the consolidation, hampers the long-term survival. So, and sometimes few germline mutations could affect the explanation of molecular MRD also. So, to integrate the various technologies in the detection methods and establish, we have to standard of care guidelines for MRD testing. We need more and more robust data and trials. Number 2, second question, are treatment strategies to eradicate MRD effective? That is very, very important question. If your MRD is positive, so whether you are going to eradicate it or what is a tool in your hand to eradicate it? Robust data not available, but some studies are going on, FLT3 inhibitors, HMAs, BCL2 inhibitors, checkpoint inhibitors, okay? But we need something like blinatumomab in ALL. So this BiTE, see, BiTE is not here in AML. So we need a good BiTE like blinatumomab. Third question, does eradicating MRD increases the overall survival? Yes, there are, this forest curve shows these data mainly skewed towards favors no MRD, but sorry, 50% of the MRD negative patients still relapse. And my question is, if my patient is MRD positive after induction and post consolidation, so we will wait for transplant or whether we go for some novel therapies? We don't know the answer yet. So how the MRD influences decision towards the allogenic transplant? The first part, the GMEMA trials, they have clearly shown that yes, in intermediate risk group, if the patient is MRD positive, okay, you can go, sorry, you can increase the risk stratification and go for the transplant. Allo transplant, if it is negative, you can go for the auto transplant. But these questions, choice of consolidation, which donor, which conditioning regime, we don't know. Whether these questions can be answered from the MRD status report, we don't know. We need more and more data for this to answer all these questions. So what is the take-home message? AML is a heterogeneous disease. MRD detection is very, very difficult in AML. There's a chance of both false positive and false negative. And AML MRD needs proper standardization, and important is a harmonization. So it is a long way to incorporate MRD in therapeutic decisions in clinical practice. So as you all know, it is the Stephen Hawking. He clearly showed that the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. Thank you, sir.
Thank you, Dr. Soumya. You convinced me totally. Wonderful talk. It was out of this world. Very impressive, very impressive. So now let's hear Dr. Ranjit Kumar Sahu.
Hi, so good evening. Am I audible? I'm sorry for the, and my sincere apologies. But I would say this had happened in the right manner. And he had just made my job pretty much easy. And I do not have any conflict to share. I mean, now, make sense is not a very scientific word, you know. And when I looked into Cambridge Dictionary, it makes, I mean, it just means to be clear and the things which are easy to understand. Now, MRD, there could be another debate between what should be the appropriate terminology, whether it is measurable or minimal residual disease. It just means that there is something which is left out, which has got a potential to regrow. And when these cells, they regrow, it actually ends up in a relapse. And there is no doubt about it. This concept is as old as 1990. Now, yeah. Now, as Dr. Shome has told, CR is the gold standard, and MRD is possibly the new standard that I might justify in few more slides. Now, this is a publication from as old as 2012, and this is the patient population were mostly pediatric population, and we know that pediatric population, they certainly do well than mostly the adult patients. And this is a prospective study. They looked into all these things and looked into both cytological complete remission as well as MRD by flow cytometry, which was mainly concentrating on the LAIP. As you could see, now these results could be discordant. I mean, mostly if it is a CR, they should be MRD negative, but there will be cases who are MRD positive. Now, patients who are having 5 to 15% blast, they could be MRD negative, and that is actually occurring in patients who are more than 15% of blast, because at this point of time, it is very difficult to assign which are the good blasts, which are the bad blasts. And when you look into the patients who have only achieved complete remission, and when you divide them according to the MRD, they are clearly divided into three populations. Those who have less than 0.1%, they have the best prognosis, and those who have got more than 1% of blast detected by flow MRD, they have a poor prognosis. Mind you, they are pediatric AML patients. Now let's see in the cohort which is classified as negative MRD, and what is the implication of having more blast? I mean, less than 5% blast versus more than or equal to 5% blast. And actually, if the patients are having a negative MRD, it doesn't matter how many blasts you see in a cytological bone marrow slide. And when you look into the patients who have positive MRD, having 5% or less blast or more than 5% blast, they actually do not make any sense. So it tells us clearly, possibly, I mean, the thing is, it is just about having a new person, which is MRD is still new, is a new kid on the block, and you are asking so many questions from MRD, and you are not comparing with complete remission. Now, complete remission had never been subjected to such intensive clinical studies. And Dr. Shome has actually told that if you ask 20 pathologists about the flow MRD, there could be a lot of discordance. But at the same time, this also happens in bone marrow cytological remissions. Now that is the thing. Between 1% and 5%, if you ask me, I am a clinician, I would rather choose a 1%, not a 5%. But when the pathologists, they come together to call it 1%, there is also not much of concordance. That's why the remission is defined as less than or equal to 5% of blast in a cytological smear. But there is more data. Now this is the biggest data which is available with regard to the role of MRD and its impact on survival. This is a meta-analysis of close to 10,000 patients, and you see that these curves are clearly delineated. Now I understood that those patients who are MRD negative initially, they also relapse, not to the tune of 50%, but somewhat 20 to 30%. But those patients who are MRD positive, they do not have a good outcome. The relapse chances are close to 70 to 80%. So as a biomarker, it is doing pretty perfect. It doesn't matter which sort of MRD you are looking at, be it a flow cytometry or an NGS based data or a PCR based data, they are pretty much corroborating to the survival. I'm sorry. Now, it also doesn't matter if the patient is MRD negative before consolidation or after completion of consolidation, it still is a good biomarker to follow. Now, and across all sort of AML, be it a core binding factor AML or a non-CBF AML, they are doing equally good. Now, let's talk about another setting, which is the bone marrow transplantation setting. Now, the impact of MRD was analyzed in this close to 300 patient study, which was published in Journal of Clinical Oncology in 2015. You could see it doesn't matter whether the patient is in active disease or MRD positive complete remission. Those patients have done well. Those who are clearly MRD negative, complete remissions, be it your event-free survival, be it your overall survival. Now, when you look into the quality of remission, it doesn't matter whether you are transplanting a patient in a first complete remission or a second complete remission after some salvage chemotherapy. In both this cohort, if these patients are MRD negative CRs, they are doing equally good. Now, this is the response criteria which was initially suggested in ELN 2017 guidelines, and it has also been there in the latest version of NCCN 2021. These are the CR categories. Now, please excuse me, I am not going to go in details about it, but CR is bone marrow blast, which is less than 5%, with a normal CBC count, almost normal, and CRI is, it is completing the CR criteria with residual neutropenia or thrombocytopenia. Now, it has also included MRD negative CR. With CR, there should be a negative for genetic marker either by a qPCR or negative by a flow cytometry. Now, if anything which is more important apart from minimal residual disease in my opinion is to look at the CBC count. When you see those patients who are achieving a CR versus those patients who are achieving a CR with incomplete recovery or CR with thrombocytopenia, you could see here that the amount of MRD positivity, it is more in those patients who do not have a normal CBC at a complete remission state. And when you analyze this data with more depth, with respect to a univariate and multivariable analysis, the two factors which are coming out pretty nicely with respect to the relapse, I am not quoting the overall survival and event-free survival, they are almost as good as this. Now, the things, first is the MRD being positive or negative. The second thing, if you look into, which is more important, is achieving a normal CBC. That is CR versus CRI or CRP. Now, if I may conclude here, now it makes logic. That is, I mean, when you evaluate a patient of AML, you do all these tests at the baseline. We know that any patient who is bone marrow is present with blast which are MPO positive, that should be sufficient to call it as AML, but still we are going ahead, we're doing a flow cytometry on the bone marrow sample, we are going ahead with a cytogenetic and RT-PCR and sometimes next generation sequencing as a part of initial evaluation of such patients. Now, these patients, after getting a usual remission induction therapy, when their response is evaluated, all these parameters should be looked in, which makes it more comprehensive. It is a more comprehensive approach towards assessing a response. It is not restricted to AML. It is there in case of, say, diffuse large B-cell lymphoma. You are doing a baseline CT scan and you are comparing with a CT scan after therapy. You are doing a baseline FDG PET scan. You are comparing with an FDG PET scan as a response evaluation. Now, this is the logic. Now, let's not make things complicated. That at workup we will do all these things, but when it comes to the time of response assessment, we are only restricting to, yes, say only bone marrow cytology, which might not be the standard, at least not for the larger guidelines. They are also not telling you that you should only indicate by your bone marrow cytology smears. Now, the second point is the data. Now, the data of MRD is robust with respect to a superior quantification of the blasts. Now, there is no doubt about it. There are good as well as bad blasts. Now, it is also robust with respect to better risk stratification of the patients. Those patients who are, to start with, they are good risk, say a CVFML, if they are not achieving MRD negativity, they might not do as well. Now, the data is borderline with respect to the treatment modification. I agree with Dr. Shomya that we do not have any Blina type drug for AML which will clear the MRD, but it is just around the corner. Then when you will be treating them with some sort of immunotherapy, be it a Blina type drug or a CAR-T or something else. Maybe allogenic stem cell transplantation, but I'm not committing more towards allogenic stem cell transplantation, which has got the potential to make them MRD negative. But the data, it is not pretty clear. Now, it is also borderline in early detection of relapse, especially in patients who have got post-PMT. Those patients who are MRD negative and they are on a continuous follow-up, MRD positivity might herald a relapse, which is in another 3 to 6 months. But the amount and the quality of data in this regard, it is not robust. Now, there are some surrogate endpoints I mean, in some clinical trials, they use MRD negative status as a surrogate endpoint, but that is still not a robust way to look into its correlation with the survival. So this might be a futuristic endpoint where we decide which drugs are okay to be taken fast into the phase 3 and to the clinic. But as of today, the data is not very supportive. Now, please address me this sort of data with respect to a cytologically complete remission patient. How much is the data which is available? So this is, I would say, this is just a modification. It is a time-bound thing. Nothing is standard as of today. I mean, less than 5% over last so many decades, we have not made it into less than 3% or less than 2% or even 1%. We are not looked at it in that robust manner. We are just happy with a complete remission. Now, by doing MRT, you're actually dwelling more beyond it. And if you ask me, as of today, if you look into the data, the two most important things for response evaluation in a patient is at least a normal CBC or an acceptable CBC, which is not neutropenia or thrombocytopenia, plus MRD. And the desirable is being MRD negative. That is possibly the best bet for a patient. Now, that should be all from my side. And thank you. I will be happy to answer a few questions or any query you have.
Thank you, Ranjit. Again, wonderful. You were also equally convincing. Dr. Soumya, you want to give any rebuttal? Though you were supposed to be the second speaker, but anyway, you want to have a rebuttal?
Yeah, thank you, Dr. Ranjit. It's a nice presentation. Um, in my opinion, what I am doing in my clinical practice, I have just started to send a sample for MRD in AML. Okay, but yes, the issue is that I don't know exactly the report what I am getting, 0.1%, 0.2%. I have asked many hematopathologists about that. 0.3%, 0.2%, this means a ton of diseases, you know. In fact, 0.1% is also, it's a disease. So if you get that 0.2% or 0.3%, what I will do? If that's my question is, okay, so in AML, APML, CML, it's okay, fine. But in case of AML, if you are after induction to consolidation, your value is 0.2. Then what you will go for? What you will do? What is the next plan?
Okay, let me. That was a very nice question. I mean, I was actually anticipating this question. Now, let me tell you, in APML, say post-induction, a patient is MRD positive by PML RARA. Do you change anything?
No, in APML, you don't need to go for quantification or RT-PCR PML alpha after induction, whether you go for after consolidation. Yeah.
Yes. It is because of two things. It is because we understand this disease is completely curable with the current age treatments. It is not based on any MRD sense. If you achieve MRD negativity even after consolidation, they will be doing well. But there is still some data. I'm not sure whether Dr. Vikram is around here or not. There is still some data about APML. Those patients who achieve an early MRD negativity, say by induction, they are doing possibly a little better than those who are MRD positive at the end of induction and achieving MRD negative. Everyone in APML with the current age treatment, they will achieve MRD negativity. Now, AML patients, the basic thing is, AML is a treatment in continuum, and as we are clinicians, we note that BMT or allogenic stem cell transplantation is not a panache. It is just a part of a treatment. So in any patient of AML, there is induction, there is consolidation, there is also some sort of maintenance to be given in such cases, just like in ALL or in any sort of hematological malignancy, say in myeloma. So in AML, being only MRD positive doesn't mean everything. You have to go to look at the biology of the patient at the baseline. Then you see what is the curability of this patient with respect to the chemotherapy. If you initially understood it is a CBF AML and it is post-induction the MRD is positive, you would wait till the first consolidation. If these patients achieve MRD negativity at first consolidation, they are more curable. with chemotherapy alone, and they might not require allogeneic stem cell transplantation. It is just the same way with respect to NPM1 mutated AML, especially those who are good NPM1 mutated AML in young patients. If they are achieving MRD negativity by an NPM1 assay, post consolidation, first consolidation, they have a better outcome than those patients who didn't. Now, there are still other patients, like those patients who are poor risk. You anyway, irrespective of the MRD data, you are transplanting them. But you have to understand, those patients who are MRD positive at the time of transplant, they are not doing good on a long run. So these sort of patients, even after doing a BMT, you still need to give some more treatment in either a way of DLI. They are not standard, but they are more of logical way of treating these AML patients, because otherwise 70 to 80% of these patients who are MRD positive before transplant, they are going to relapse. Now for intermediate risk, you will be doing just the same. Now you have actually mentioned about the DAT mutations. Well, what are its logic? They are age-related mutations, and it has been clearly shown in multiple set of data that presence of these age-related mutations at remission with clearance of other driver mutations, and also the flow cytometrically achieving MRD negativity. Possibly that doesn't add to more adverse prognosis. So these things are pretty much clear. I agree with you that these things are not standard as of today, but even
Exactly. Exactly. After this debate, I think the most important part is that two things. First, what investigations, what we are doing, that is the whether it may be due to the flow cytometry or molecular based test, whatever it may be, that should be properly standardized. A lab should intimate. Exactly. No, that is the problem. Otherwise, the clinician, being a clinician, we are in a soup. Sir, may I ask you, sir, in your clinical practice, what you are doing? Agarwal, sir.
Oh, you're asking Ranjit or Agarwal, sir?
I'm asking you, sir.
So I never changed my policy with the MRD in AML. And after listening to both of you, I'm convinced that what I'm doing is quite right. There are about 7 minutes, and there are some questions from the audience, not exactly related to what you two have spoken, but they are on some very basic aspects of AML. Will you answer for the benefit of our audience? Two of you are willing for that? Okay.
Yes, sir.
So
Yes.
first question is, are you using levofloxacin as a prophylaxis in Indian context when this drug is approved as a second-line anti-TB drug in India?
So we are
Sir,
not using it routinely.
Yeah, we are using, sir.
So I'm using, you're not using. So if you're not using, what are you using?
So we are not using any antibacterial prophylaxis, sir. And levofloxacin in all our bacterial this thing, they are all almost, it is close to 100% resistant. 100%. So it is not wise, yeah.
All right. The second question is, do you use GCSF during cytopenia in AML induction?
Yeah, I am using it.
So I am not using it.
Any chance of disease relapse by using GCSF?
So there is actually no chance. If the data is convincing, actually it doesn't add to any bad this thing.
Exactly.
Possibly we do not use GCSF that much in cytopenia, only in individualized situations.
The third question is role of surveillance stool and throat cultures before starting intensive chemotherapy.
Regularly, in regular basis, we are not going for any surveillance culture before starting 3+7 or intensive chemotherapy. But before transplant, it's yes.
Ranjit?
Yes, sir. It's not a routine. We are actually evaluating it as a dissertation.
Okay. The next question is, which is same as what we discussed, GCSF. Next one is, if the baseline albumin is less than 3 grams, does it affect your treatment policy?
No. So that is not a single biomarker which should affect your treatment policy. Exactly. I think that will be reflecting in the performance status of the patient. If the performance status is more than 2, then it is very difficult in such cases. So
I agree with Dr.
Yeah.
Thank you. What's the next question is, what is your experience of using dose-adjusted GO during induction treatment? Gemtuzumab in induction treatment, dose-adjusted.
So practically speaking, I have not used, sir.
You're not used.
No experience, sir.
No experience. Last question is, how do you manage prolonged neutropenia in limited resource setting?
That's a good question. So as of today, we do not have anything. GCSF might help in reducing the days by a day or two. That might be one useful thing. But if the patient it gets sick, they have infection, at times granulocyte transfusions can be considered in such cases.
I suppose they were asking this, are you using granulocyte transfusions?
So, not as a routine, only in personalized cases.
Exactly, sir. Me too, same.
Unusual modality when you have first aid law. So I think, thank you so much. That was a wonderful debate. And I think a lot of people must have benefited, almost all must have benefited. Both of you did your best. Thank you. And thank you for joining this webinar. It added a lot of value to it.
Thank you, sir.
And my apologies once again, sir.
Not at all. Not at all. So it didn't matter really which way it went. As you said, that probably this was the right way.
Yeah.
We formulated it wrongly.
Yes.
Okay. So fourth part of our webinar, which is the last part, and those of you who have joined late, this webinar, 5 days long, is a baby of Dr. Reddy's, executed by Mumbai Hematology Group, entitled Year in Review Hematology 2021, so that we discuss what has been presented and published in last 10 months during the current year. Can we go back to the previous slide? Is it possible? Yeah. So Dr. Reddy's are launching oral azacitidine, a very, very relevant molecule, as you will see in this part of our particular webinar. Now we are coming to review of the papers published or presented during 2021 in the field of acute myeloblastic leukemia. We have three wonderful speakers. First is Dr. Bhausaheb Bagel, who is professor, consultant medical oncologist, and BMT physician at TMC Mumbai. He's going to tell us about exactly what we were mentioning: continued treatment of AML, the role of azacitidine tablet. This will be followed by Dr. Deepesh Lad, clinical hematologist, oncologist, and BMT physician in Department of Internal Medicine, PG at Chandigarh. He's going to touch an entirely different subject: germline predisposition syndromes and acute myeloblastic leukemia. And last but most important is Dr. Chandran Nair, professor and head, Department of Clinical Hematology and Medical Oncology at Balaba Cancer Center at Thalassery, Kerala. And he's going to talk to us about secondary AML. So let's begin this session with Dr. Bhausaheb Bagel on oral azacitidine maintenance.
Thank you, sir. Thank you for this opportunity to speak, and I will just share my presentation. Yeah. So I think we had a good discussion right from diagnosis of acute myeloid leukemia to the induction and then some role of MRD. And now we move on to a very timely topic, that is continued treatment in AML, role of maintenance azacitidine in form of tablet based on the recent data. So this concept of maintenance is not new. And first of all, we need to understand and get convinced why we need maintenance, because first of all, the outcome of AML are really not great. We see significant relapses across the risk groups in AML, even if when they are giving required induction and consolidation as per the current standard treatment. Second thing is, once they relapse, the treatment is really difficult. So it might be difficult to get remission in very small subset of patient, but the major problem now we face is probably maintaining the remission in this patient. And that's the thing. Once you relapse, you can get second remission and then plan a treatment, but this is actually titled in some of the articles as myth of second remission, because some of the reported series in the reputed institute report outcome of 10 to 15% in a relapse acute myeloid leukemia setting. And you can imagine what will happen in a real world setting. A second thing is, once you have controlled the disease, you have done the induction and consolidation, you have a better patient to manage. So this person has an improved performance status, his disease burden is less, so his bone marrow function is recovered, and that is why we expect a better tolerance. So definitely this is a very logical thing to try in this patient when we will have a good patient. Second thing is in post-transplant, second immunomodulation, probably a naive immune system which is developing after allogenic transplant is amenable to immune modulation, and that is another motive for trying immunomodulatory strategies as a part of maintenance therapy. And we know from various diseases like AML or myeloid leukemia, multiple myeloma, that maintenance can be associated with the overall survival advantage. And based on this background, maintenance has been tried and tested in AML for decades. And as Dr. Velu Nair said, probably we'll be seeing the role of maintenance, but this strategy has been tried for more than 4 to 5 decades. What we initially saw was the chemotherapy-based maintenance, which was either a low-dose chemotherapy or intense chemotherapy-based maintenance, and there was no benefit. Some of the studies showed some of a progression-free survival or a disease-free survival benefit, and it was mainly limited because of the toxicity of the drug, same mechanism of actions of the drug, because we didn't have good tools which were not available at that time. Then the next approach was immunotherapy. It was mainly in front of interferon, interleukin, and vaccines in those era, and we will see some of the data. And now we see some data with the lenalidomide also, but very kind of thought-provoking or different approach of having maintenance. But what is shown on the right side is the potential candidate right now we have, and I think one of the very competent candidate is epigenetic modulation by hypomethylating agent or HDAC inhibitors. And we also have targeted therapies of FLT3 inhibitors, IDH, BCL2, and the list goes on. And probably we'll be seeing more maintenance studies using these targeted therapies. And finally, we may have some resurgence of immunomodulation in form of checkpoint blockers, as we have better immune modulation tools to do nowadays. So immune therapy as maintenance, and I will just show one presentation on this. This is a large meta-analysis of number of trials of IL-2 done as a maintenance therapy in acute myeloid leukemia. And this include, I think, roughly 10,000 patients. And what you could see in this meta-analysis is IL-2 done repeatedly in this across multi-center trial did not show any improvement in the disease-free survival or overall survival. And some studies show some advantage, and some indication is changed, and some reference study is done, and this kept on happening for quite some time. And so I would like to point a interesting study where interleukin 2 was combined with histone deacylase inhibitor, and this simple compound, which was supposed to activate the NK cell and T cell, led to some improvement in the progression-free survival, but not in the overall survival. So the problem is the result of maintenance studies are not really consistent, and we always find some or other reason why they are inconsistent. But basically, the old immunotherapies were not really a breakthrough. Now we are hypomethylating agents. So we are used to using these drugs, and many single-arm phase 2 studies have shown that it is feasible. We have to use this drug either intravenously or subcutaneously with azacitidine, and the feasibility in terms of tolerance has been shown, and some activity has been shown in the single arm studies in the both transplant and non-transplant setting. And this sets a background for studying this agent further in the larger cohort of the patient in the randomized setting. I will show a couple of studies with the injectable form of hypomethylating agent. So this is a single center study from this is some American center. I think it's from MD Anderson, and where they used azacitidine as a maintenance after stem cell transplant in high-risk AML and MDS patient. And what they used was a lower dose of 32 milligram per meter square for 5 days. And this study took quite a time to kind of enroll this patient, and this finally did not show any difference in terms of relapse-free survival or overall survival. And this is their experience from the MD Anderson, a single center study. But there are many lacunae of this study. The time for enrollment, the inclusion criteria, the number of cycles were not really uniform, or most of the patient did not receive required treatment. Another study which is kind of very interesting is a HO197 study. So this is a study group done by the AML study group, where older AML patient or high-risk MDS patient after CR were randomized to either no maintenance or maintenance azacitidine, and the dose was again injectable 50 milligram per meter square day 1 to day 5 every month for a maximum of 12 months. And you could see that there was a nice disease-free survival advantage in this study, but there was no overall survival advantage in this study. This study also tried to dissect out who is likely to benefit. So what this multivariate analysis show, that person who has achieved a CR rather than a CRI, so a very good recovery of bone marrow impacting towards a healthy bone marrow, probably this patient achieved a better disease-free control with this maintenance strategy. And second was platelet more than 1 lakh. So basically, this points toward that patient who had probably a good risk disease or who had cleared their MRD benefited by this approach. But definitely, this study was a very small study, and this study probably generated a lot of enthusiasm with this agent. We also have a study in the stem cell transplant setting using a oral CC486. We have a ongoing AMEDIAS study randomizing patient after transplant to oral azacitidine versus observation, and the result of which are eagerly awaited. But this study showed that it is feasible. So this was basically a dose finding study where they found that 200 milligram every 14 days was a tolerable dose post transplant. And this study showed a very encouraging outcome, 72% 1-year outcome in post transplant setting. So this also probably gives us a hint that probably AMEDIAS result would be really awaited, and we may have something positive there as well. So after this lot of studies, probably we need to look why maintenance studies are often showing conflicting result and why they are difficult to treat. And this is a very nice cartoon which is given editorial by Andrew V. So what he says that AML, if you have a diagnosis, the person has to cross too many things. So he has to cross this induction, achieve a CR, has to go on to consolidation, and finally we could go on to a maintenance study. So there could be many detours. So he may be unfit for treatment in the first go itself, or he may not go into the remission and then he's out of study. So there are many chances that these people would not end up receiving maintenance treatment versus observation in the study. And because of this, the studies are difficult to do and the result might be conflicting. So given these challenges, probably doing a good study is not a easy task, and that's why we are really happy that we have this study of oral azacitidine maintenance in acute myeloid leukemia setting, and this is something which we'll review in detail. So looking at the quality of the study, so it is very high quality study, randomized controlled trial. It is including it is a double blind placebo control study. So neither patient nor the investigator were aware of what they were receiving. So that is very good. The eligibility criteria, probably we should pay attention because that is what is relevant to this discussion, is intermediate and high risk acute myeloid leukemia, patient achieving CR or CR after intensive induction, and these people are not transplant candidate despite being intermediate or high risk acute myeloid leukemia. They were treated with CC486 300 milligram OD day 1 to day 14 for 28 days versus placebo. And in this study, every patient underwent a bone marrow at 3-monthly interval. And at any time point, if they see that the blasts were increasing in the blood or peripheral blood or bone marrow by, from 5 or in between 5 to 15%, the dose could be increased from 14 days to 21 days. And the endpoint was, primary endpoint was overall survival, so very robust endpoint, and other were the relapse-free survival and the safety of this drug. So you could see the consort of the study. So very large study, more than 500 patients were screened, roughly 475 were randomized to 2 arm of observation versus CC486, and we see the result, we see the baseline characteristics here. So this is important for us to realize. I think the eligibility criteria or the study population represent what we see day in and day out in our in your and my clinical practice. So most of these patients were intermediate risk, roughly 85% in the both arm. This patient had received 2 or more courses of induction in at 20 or 18%. So probably most of our patients will receive 1 induction. Then complete remission was there in 80% in both the arms. So most of the patients were in CR, not the CRI category. Then a vast majority of the patient had received a consolidation treatment, roughly 75 to 80% of the patient. And important is there positivity for minimal residual disease. So this was roughly 50% in both the arms. So this is probably a garden variety patient which you and me probably will be treating, and because of various reasons will not be able to do their transplant because it is not feasible or the person is not eligible for various reasons. And this is the result. So this is, I first talk about the relapse-free survival, which was a secondary endpoint, not the primary, and you could see that the relapse-free survival increased from 4.8 months for this patient, very short, to a decent prolongation of 5.3 months, so leading to a roughly 10.2 months increase in the disease-free survival. And this is in a intermediate to high risk acute myeloid leukemia not undergoing transplant, so very difficult to treat population. But most important is overall survival difference, and this difference was increase in the overall survival from 14.8 months to 24.7 months, roughly 10-month increase in the overall survival. And we really don't see studies showing overall survival in the acute myeloid leukemia setting, and even in the maintenance setting they are even very rare. So this is something really encouraging to look at this. Now we go to subgroup analysis, and see was there any subset which benefited or which did not benefit. So you could see that across the various subgroup which are shown in this in this table, everyone benefited. And when you look at the right side, I first thought these are hazard ratios, but no, this is very high. And then I checked, this is not hazard ratio. This is a 2-year difference in the overall survival between the two arms, because of some statistical issues, they could not give hazard ratio. But you could see that everyone benefited. And if you look at some of the thing which we want to do, so for example, across this there was a benefit. Then patient with having antecedent MDS or other CMPDs, they also benefited. The benefit was there in intermediate also, and the poor is acute myeloid leukemia also. Then a number of consolidation cycle used also, and CR, I would say, so MRD positive and negative patient also, everyone benefited. So number of patient in the individual subset may be very small, but as you could see that most of the patient subgroup benefit tend to benefit. And this is quite good to know about this study. Coming to tolerance, so we're always worried about doing something to acute myeloid leukemia patient, and as you would have expected, these patients were in remission, the tolerance was really good. So as compared to placebo, which saw 63% grade 3 or grade 4 adverse event, and most of them were biochemical or hematological abnormalities, the number was 72%, so roughly a numerical increase of 9%. So important to note is neutropenia, it was 24% versus 41%. So definitely neutropenia has increased, and we need to be thoughtful or mindful about this. Again, thrombocytopenia was almost same in both the arms, and febrile neutropenia incidence was 8 to 11%. So looking at this, definitely it looks tolerable, but we need to have our own experience or our own data for this. And I'm sure as we use this drug, we'll have more experience. So coming to its appraisal, so probably this is a very good planned study, placebo-controlled, multi-center, double-blind RCT, and this is what we want, though this was a pharma-sponsored study. This study has collected samples for molecular analysis of subset, but it is not reported as of now. So we don't know what molecular subset benefit more or which do not benefit. One thing which I didn't like was the step-up dosing when they saw a blast from 5 to 15%, and they increased the dose of placebo in the arm when they were not knowing it. But probably this has not reflected in the overall survival change. So probably this was not a major issue. And it also makes me think why earlier studies of randomized control trial of injectable azacitidines did not show a difference when you have a same kind of compound but which is given in a different day. But definitely leaving aside, this is a visual abstract from the NEGM, which aptly says that a very large number of patients in this study, when they were treated with an oral quite comfortable tolerance with this drug, it lead to prolongation in overall survival of roughly 10 months, and similarly increase in the relapse-free survival. So definitely a good thing to have at this time point. So with this, I will end, and thank you for listening, and hand it over to Agrawal sir.
Thank you so much, dear. Any questions from the faculty here? Questions in the question box are not connected with your topic, so we will not cover them just now. But if anybody wants to ask any question from the faculty. Okay, I have one question, Hausain.
Yes, sir.
Most of the patients had received 1 or 2 consolidation cycles. 3 consolidation cycles were 6, and 1 or 2 consolidation cycles were 100 plus. Now, does this mean that this maintenance work like consolidation?
Sir, I think we have to see it like a continuous treatment, as we see in many diseases, etc. And sir, right now we are not in a position whether a person who is suboptimally treated or has a residual disease benefit more, so as we saw from the MRD subset analysis. And this is also a common thing, sir. For example, in a high-risk patient, many times we are not able to deliver the required or a third consolidation in our practice. So definitely difficult to answer your question as of now, but definitely a thing to note in the analysis.
Right. Thank you. So we move to the second lecture, Deepesh Lal.
Thank you, sir. Good evening, everybody, and thank you, sir, for the kind invite. And touching a topic which we usually do not discuss at meetings. So I'll be discussing about, is my slide visible?
Yes.
So I've been told to discuss on germline predisposition to acute myeloid leukemia. I'll be excluding the inherited bone marrow failure syndromes because this is a topic in itself and there are specific guidelines to it. And rather than giving an update of what has happened exactly in the last 1 year, because predominantly what has happened in the last 1 year about this topic is addition of new mutations to the germline predisposition. So I'll give you an overview of a topic which we usually do not discuss. So why is it important to discuss this germline predisposition? So 5 to 15% of adults and around 4 to 13% of pediatric MDS AML patients will carry a germline pathogenic variant in the cancer susceptibility genes. So it provides an explanation why they have the disease, and it helps us to tailor the therapy, select donors for transplant and conditioning regimens for transplant. And you need to be aware of their extra hematopoietic manifestations and interventions for it. And also for genetic counseling and following up at-risk family members. So this is from specifically Nordic guidelines, which were published in Hemasphere in 2019 and a recent update in 2021. So who are these patients who are where we should suspect germline predisposition? So one is family history, which suspects there is signs and symptoms of hereditary predisposition. I'll come to what are the signs and symptoms. So any patient with AML and MDS who has these signs and symptoms, or a patient who has first degree relatives or second degree relatives with MDS or AML with or without long lasting thrombocytopenia and signs and symptoms, or relatives with even solid cancers. And these are one group of patients where you would suspect these patients to have germline predisposition. Second is predominantly, you have acute myeloid leukemia where you do a germline, where you do a somatic genome mutation panel, and you detect the variant allele frequency is very high, 40 to 60% or more than 90% in either RUNX1, GATA2, or ETB6, EBPA genes. These are patients where the probability of these somatic mutations are likely to be germline, though a normal result on a somatic genome panel does not preclude germline mutations. Another group of patients where it is important is patients with AML MDS with age less than 50 who have monosomy 7 or deletion 7q. These are patients who are likely to have GATA2 or SAMD9 germline predisposition. So this is a revelation because this is not something which we routinely look at in these group of patients. So most important thing is to have a good family history and a pedigree chart. Now this is how a detailed pedigree chart should be in these patients, and it is just not asking a history of whether there is any history of blood cancers in the family. It is also asking about whether there is a history of thrombocytopenia, unexplained bleeding manifestations, myelodysplasia, MPNs, and that's how a detailed family history should be. And to get to that detailed family history, you might need to use this screening questionnaire, which was developed by the University of Chicago. And it has specific questions which you will need to ask your patient and the family to have a positive family history. And these are the signs and symptoms of the hereditary predisposition to myeloid neoplasms. Some of these are common to the inherited bone marrow failure syndromes, the telomere syndromes, and some common to solid cancers associated with TP53 mutations. The others are predominantly seen with GATA2 in the form of immunodeficiencies, opportunistic infections, also a history of excessive toxicity to chemotherapy or radiation should lead to suspicion, and poor stem cell mobilization in donors, which we have seen in some cases. And of course, thrombocytopenia and family members should lead to a suspicion of RUNX1 germline predisposition. So this has led to the WHO acknowledging the presence of myeloid neoplasms with germline predisposition. So the commonly mutations are CBPA. DDX41 is a myeloid neoplasm which could happen in an older age, but it is still associated with the germline predisposition to AML. And then RUNX1 is associated with 45% risk of myeloid malignancies. Other common mutation is GATA2, associated with 80% risk of myeloid malignancies. And SAMD9 associated with monosomy 7 in AMLs are associated with germline predisposition. So how do we evaluate these patients? So if you're looking at a screening or a research tool, whole exome sequencing or whole genome sequencing will help you get to novel mutations in these myeloid neoplasms. But you may need to complement them with either copy number variant calling or microarray testing. You commonly do somatic gene mutation panels in myeloid neoplasms, But to look at germline variants, you might need to test extra hematological tissues. So for this matter, you might use the skin biopsy that you get along with the bone marrow biopsy. And the fibroblast cultured from the skin biopsy might be the extra hematological tissue that should be used for detecting germline variants. Because the blood will be contaminated with the myeloid blasts, and it will be difficult to differentiate whether they are germline or somatic. And then, of course, you could use the blood if the patient is in remission in selected cases. And it is always important to have pre and post-test counseling of these patients and family members. So once you identify a mutation through different panels, whether these mutations are variants of unknown significance or variants of pathologic significance, you need to go to a tool which is ClinGen Myeloid Malignancy Variant Curation Expert Panel. This was developed in association with ASH and ClinGen, where they have mentioned the gene and disease-specific modifications for inherited myeloid malignancies. So you insert the gene that you have detected, say for GATA2, and all the variants that have been accepted as to be associated with pathologic significance are kind of curated in this reference website. There are the RUNX1 mutations are associated with various spectrum of hematological phenotypes. As you can see, they can be associated with just thrombocytopenia. These are the variants associated with acute myeloid leukemia, as well as other conditions in hematology. So how does it help, and what do you do once you have germline predisposition detected in these patients? It's important to have a surveillance in plan for these patients. You might so there is variable penetrance, there might be mosaicism, reversion in these cases. So there are not definite guidelines. These are based on basically some expert recommendations. So you might do a CBC with manual differentiation counts every 6 monthly. You will need to do a bone marrow aspirate and biopsy, cytogenetics and NGS myeloid mutation panels. These are all suggestions because there is no accurate way to kind of follow these patients. These are from the Nordic guidelines, which say that they do it at baseline and annually NGS myeloid gene mutation panel in these patients. And of course, family planning before any pregnancy. It helps to decide allogenic transplant for these patients because the indication is often not just occurrence of cytopenias or progression to acute myeloid leukemia. These patients may have other organ dysfunctions or life-threatening immunodeficiency, which might also be an indication for allo transplant in these patients. And it helps to choose the donors because you need to choose a asymptomatic, you need to avoid an asymptomatic carrier to avoid graft failure and donor-derived leukemia. You need to choose reduced intensity conditionings or non-myelolytic conditionings to avoid toxicity from transplant. And you need to follow up these patients closely for the risk of secondary cancers post-transplant. This was a recent publication from a North American, multiple centers in North America, where they looked at a large cohort of adult AML patients, around 400 in numbers. And they were able to detect novel mutations in germline variants in up to 13% of this cohort of 400 patients. So it's pretty common. And the variants of unknown significance were as high as up to 60%. And depending upon the strength of associations with myeloid malignancies, they were classified from tier 1 to tier 5. So to conclude, germline predisposition in myeloid neoplasms is more common than you think. You need a high index of suspicion. You need to be aware of the spectrum of the presentation. You need a detailed family history, and you might need to use specific questionnaires. And you need to do a targeted NGS panel of extra hematological tissues to confirm the diagnosis. Whole genome sequencing or whole exome sequencing is a research tool for screening. You still need to confirm whether these variants are of pathologic significance or unknown significance using curated data tools like the ClinGen data. And you, of course, need to do genetic counseling both pre and post test for the patients and family members. And you need to be aware of the clinical implications in terms of either following up these patients or selecting them for transplant and subsequent follow-ups. That I thank you all, and I'll be happy to take if there are any questions.
Thank you, Deepesh. Great coverage. Questions from the faculty present here? There are none in the question box.
Dr. Deepesh, I have a practical question. So in your routine clinical practice, do you, in any of the situation for an adult AML, is there any situation where you screen for inherited marrow failure syndrome?
Sir, in my clinical practice, I have just seen 2 patients so far. One was reported just last year, which was a RUNX1 germline mutation, and that too was kind of suspected because when we are planning to transplant this patient, the possible donors had thrombocytopenia. So then you start digging up the family history, and then you notice that several family members have a history of thrombocytopenia. And that's how you then lead to a targeted RUNX1 testing to see whether there is germline mutation in the family members or not. The other was GATA2. Again, GATA2 is very difficult to suspect because these patients might have immunodeficiency just like your myeloid neoplasms, like your AML. But they have additionally, predisposition to variants of tuberculosis. They have monocytopenia. They may have extra hematological manifestations in the form of pulmonary alveolar proteinosis. So often you need to be aware of the spectrum of the presentation, and then you might suspect these rare disorders. So once you have GATA2, then you definitely, if there is other organ dysfunction and there is AML, you need to transplant these patients. And then you need to be aware of selecting the proper donor and the conditioning regimen changes. But in routine practice, it's very difficult. As I suggested, it's starting with the proper pedigree charting, it's often about proper history taking, and you need to pick up these patients more.
Thank you.
Thank you. Any other question for Deepesh? Okay, if none, then now Dr. Chandran. And thank you so much, Dr. Deepesh.
Thank you.
Thank you, sir, and thank you, MHC, for giving me this opportunity. So I'll just share my screen. So my topic is on secondary AML. So I'll be touching upon a few important papers which are presented in conferences last year, as well as one published paper also I'll touch upon. So this is a published paper. This is actually an updated data, 5-year updated data on an already published randomized controlled trial, where CPX351 is compared against 7+3 induction in untreated secondary AML patients in elderly age group, that's 60 to 75 years, but who are able to tolerate intensive chemotherapy. So standard induction 7+3 was compared against induction with CPX. Actually, CPX is a liposomal encapsulated form of daunorubicin cytarabine combination in a 1:5 molar ratio. So after induction, consolidation cycles were given up to 2 cycles with CPX351 or 5+2 regimen up to 2 cycles. The primary outcome was overall survival. So what we can see is the CPX arm has significantly improved the overall survival. This is for the entire cohort. So we can definitely say the CPX is far superior to the 7+3 arm with regard to overall survival. And when we look at the number of the entire cohort of patients who underwent transplant, even those patients who underwent transplant, there is a difference in patients who had received CPX versus 7+3. Means around 60 patients in the CPX arm underwent transplant, around 39 underwent in the 7+3 arm, but still the CPX arm was superior in terms of overall survival. So the authors concluded that CPX was superior to conventional 7+3 with regard to overall survival, and this improvement in survival was regardless of age group. Means they had compared age between 60 to 69 versus 70 to 75, and whether people have underwent transplant or not, that picture I have shown. And among patients who achieved complete remission either with CPX or conventional 7+3, still when they studied about people who achieved CR, there also the difference in the overall survival was significant. So the final conclusion was it's a potentially deeper response initiating agent, and which is able to induce long-term remission and survival in elderly patients in newly diagnosed high risk or secondary acute myeloid leukemia. Then others are a few abstracts, 3 abstracts I'll be touching upon. So we know that secondary AML patients, you usually have this TP53 mutation. So, around 30 to 50% of therapy-related AML or secondary AML patients have this mutation. And it has been shown that a course of 10-day decitabine has shown good efficacy in TP53 mutated AML. So basically the hypothesis was, can we further increase or improve the efficacy of this decitabine in this particular mutated group of AML by adding venetoclax? So this was again elderly AML age group, 60 years of age or older. Decitabine was given at 20 milligram per meter square in a 10-day course, and the induction induction was up to the course was every 4 to 6 weeks. And once patients achieved remission, the 10-day course was reduced to 5-day course, and venetoclax was given as 400 milligram daily dose. And the assessment of TP53 mutation was using next generation sequence panel. So these were the results. 121 patients were recruited. So what we can see is 31% of patients had TP53 mutation, and as expected, majority of the TP53 mutated patients were more likely to have therapy-related AML, adverse ELN risk group, as well as less frequently to have other types of mutation like NPM1. So when we look at TP53 mutation versus TP53 wild group, it is clearly seen that the rate of complete remission or complete remission with incomplete count recovery or MRD negativity, everything was far inferior in the mutated group compared to the wild group. And even when we look at the overall survival as well as progression-free survival curves, the TP53 mutated group fared inferior. Means overall the results suggest that there is no definite advantage, or venetoclax addition to the decitabine could not negate the bad prognostic result of TP53 mutation. Basically, this is a negative result study. So this is another abstract where a combination of azacitidine is combined against a RARA agonist. So RARA agonist means the basic principle is 30% of newly diagnosed acute myeloid leukemia patients will have RARA positivity. And another thing is, if somebody has got an AML with a RARA positivity, it automatically implies venetoclax resistance. So there is no point in combining azacitidine with venetoclax in this particular group of AML with a RARA positivity. So the investigators did, they took a group of newly diagnosed AML patients unfit for intensive chemotherapy, and both RARA positive and RARA negative patients were recruited for the comparison purpose. Azacitidine was given in standard dose, and from day 8 to day 28, this oral RARA inhibitor was administered. So the primary objective was overall response rate. So 51 patients were recruited, both positive and negative group were there. 22 were RARA positive, 29 were RARA negative. Median age was higher, and and 43% of patients were having secondary acute myeloid leukemia. So when we look at the results, this is contrary to the previous paper, the presence of RARA positivity. When we add this particular agent to azacitidine, it definitely improved response rate, complete remission rate, as well as median time to achievement of initial complete response. In RARA positive group, it was 1.2 months compared to 2.9 months in groups with RARA negativity. And another point to note was those patients who achieved complete response in RARA positive group achieved actually good number of around 90% achieved complete molecular or cytogenic response also. Means the point is this particular combination is able to induce deep molecular response. So the authors concluded the combination of this new agent along with azacitidine was well tolerated, and the side effect profile was almost comparable to single agent azacitidine. And the complete response rate as well as rapid time to initial response was also much better when compared to RARA negative group and also compared to azacitidine monotherapy. So this may be very good potential option for newly diagnosed unfit AML patients with the RARA positivity. And another secondary objective was the assessment of transfusion independence in this entire AML group. So what they could conclude, in RARA positive group, transfusion independence was achieved in majority of AML patients. So this is the last abstract. So this is actually anti-CD47 antibody. So which is combined with the azacitidine in acute myeloid leukemia patients, basically phase 1b study. So CD47 is if it is expressed on tumor cells or leukemic cells, it will act as something like a don't eat me signal. So which actually blocks the macrophages in phagocytosing leukemic cells. So magrolimab is an antibody against this CD47. So once a CD47 is blocked, the leukemic cells are changed into a eat me signal type of thing, so that there is the magrolimab can induce tumor phagocytosis, as well as this action can happen even at the level of leukemic stem cells. So it is also in preclinical studies, it was found that azacitidine synergizes with the magrolimab in this particular action. That means improving the eat me signal. So this is actually this abstract is a updated data on the phase 1b study of this particular combination in patients with untreated AML. So treatment naive AML patients unfit for intensive chemotherapy were recruited. And because being a phase 1b study design, dose escalation schema was used for the magrolimab part, but azacitidine dose was as per the conventional standard dosing. So the important results from this study, 52 patients were recruited, older age group AML only, median age being 73. And more than 60% or up to 2/3 of patients had poor cytogenetics, and up to 65% of patients had TP53 mutation, which is more relevant for our topic, because we were already stating secondary AML have more incidence of TP53 mutation. And this, when safety profile was shown, it was well tolerated, and the safety profile was almost similar to single agent azacitidine. Because this is a checkpoint inhibitor, always some immune related adverse events were expected, but fortunately in this particular phase 1b study, no immune related adverse events were observed. And looking at the response rate for the entire cohort of the 52 patients, overall response rate was 65%, with CR rate of 44%. And another point was the time to response was also rapid, with median 2.04 months, which we all know it is much faster than single agent azacitidine. Now with this response rate, when compared against patients with a TP53 mutation, so interesting find is those patients with AML with this TP53 mutation, the overall response rate was much better than the entire cohort. Overall response rate of 71%, and even CR rate was higher, 48%. And so another point was bone marrow leukemic stem cells were also eliminated by the combination in 71% of all responding AML patients. So basically the point is, the authors concluded it's a basically immunotherapy, novel immunotherapy, basically targeted sort of therapy against leukemic cell, as well as which can target even leukemic stem cells as a targeting agent. The combination is well tolerated. And most important point is, in AML patients with TP53 mutation, there is high amount of efficacy, so which is a potentially explorable option. So the final conclusion was it's particularly encouraging in TP53 mutant acute myeloid leukemia. So with that, I would like to stop. Thank you very much.
Thank you so much, Dr. Chandran. Beautiful 3 abstracts, and wonderful. Even answer to TP53 mutation. Questions? Okay. There appear to be no question here. Is Dipesh around?
Yes, sir. I'm here, sir.
There was one question. is there a genetic predisposition to APML?
Yeah, sir, I just kind of answered it. So I was just looking on Google, and there's only one case report that comes to notice that's published in 2000. Just 2 cases who were in the same family. But that's just an hypothesis. I think over a period of time, as we start doing, as more and more screening studies will involve whole genome sequencing or whole exome sequencing, we'll detect novel mutations which need to be curated for their association with pathologic significance. So probably over a period of time, the spectrum will keep on expanding.
Thank you. So well, thanks Chandran, thanks Dipesh, thanks Bhausab. This was a lovely 4th segment of 3rd day of our webinars. I think a lot was achieved. Everybody must be very happy. On my behalf, I thank everybody who was involved. For the official vote of thanks, over to Mr. Abhishek.
Good evening to all. I would not take much time. Just wanted to thank all the respective faculties and Dr. also for this wonderful program. I personally also enjoyed this discussion. And just before closing, I would request everyone, if it is possible, there are another 2 days left for this event. It would be great to have you all for the next 2 days. Thank you very much. Good night.
Thank you and good night. Thank you.
Thank you. Good night.
Thank you, sir. Good night.